We'll start, ma'am. Very good evening to one and all.
Sahiti.
Good evening to all the faculty members and delegates present here. Myself, Sahiti from Shield Connect. I welcome you all for today's webinar on infectious in pregnancy, organized by Safe Motherhood Committee, OXI. So let me introduce the MOC of today's webinar, Dr. Bharani. Ma'am is the member of Safe Motherhood Committee, OXI 2023. And ma'am has done DGO from Madras Medical College and DNB from Apollo Hospitals, Chennai. Former assistant surgeon at District Headquarters Hospital, Neelagiris, and ma'am has received gold medal in MBBS, TNMGR University, and second in DGO. Ma'am has presented many papers at national and international conferences and published articles in journals of repute. So I welcome you, ma'am, and I hand over the session to you.
Thank you. A very good evening to one and all. Today's is going to be a very interesting session. I'm going to quote William Shakespeare from Romeo and Juliet, where he writes, "Take thou some new infection to thy eye, and the rank poison of the old will die." This can be only said about love. Any other infection in the body is a real nightmare, particularly in pregnancy. And as Florence Nightingale said, wise and humane management of the patient is the best safeguard against infection. Today, we're going to discuss this pesky issue, infections in pregnancy, and be enlightened about the best safeguard against them by experts. But as is our usual routine, we will begin with a Tamil Thai Varthu, followed by the virtual lighting of the Kuttuvilakku. I now invite our
Oxy prayer, Bharani Oxy prayer.
Yes, ma'am. I invite our vibrant secretary, Dr. Kundavi ma'am, to give us the Oxy prayer and start the session.
Thanks, Bharani. Can I have the next slide?
Ma'am, it's there.
Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn. The courage to deal with it when things are not perfect, and to remember that we are but the messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you.
Thank you, ma'am. Now I would like to invite our dynamic president, Jairani ma'am, to give the welcome address and welcome our chief guest and guest of honor for today.
Thank you, Bharani. Thank you. So, Good evening, dear friends. Respected Chief Guest Alka Madam, Guest of Honor Vidya Madam, Senior Faculties Dr. Palniyappan Sir, Dr. Vijayalakshmi Balakrishnan, our Treasurer Kalai, and the senior faculties, Dr. Preeti, Dr. Vidya, Madam Vijayalakshmi Sheshadri Madam, Dr. Mr. Prabhu, and Dr. Angeline Selvaraj. I welcome you all on behalf of OXY 23 for this wonderful webinar on infections in pregnancy, well coined and well modulated and well prepared by the committee chairperson, Dr. Rajeshri. A very special thanks, Rajeshri, for making this wonderful webinar on the infections in pregnancy, which is a real important things that we all face day to day in our clinical practice. And we have very senior persons here to talk on this. I welcome you one and all. And it gives me great pleasure to welcome and introduce the chief guest for this webinar, Madam Dr. Alka Pandey, who is the Vice President, FOXY.
Right.
Yeah. Madam is the Professor in Department of OBGYN Medical College, Narayana Medical College, Sagarsa. And she is the Vice President current of the North Zone 2020-24. And she is the organizing chairperson of the FOXY Vice President Conference on 2023.
Okay, Jarani. Thank
Madam,
you so
over
much.
to you for your kind words, ma'am.
Thank you so much for giving me this opportunity, Jarani. And it's really wonderful to see you all on this platform. And my regards to everyone and my love to everyone, to Jarani, Kunjavi, Vijayalakshmi ji, Palani Bharani, Vidya Thobi ji, and Dr. Rajshri, who has organized this webinar. And this is something not very common, which we usually discuss in Safe Motherhood Committee workshops. Usually, we are discussing about hyperglycemia, thyroid problems, PPH, labor problems. So, infection is lesser discussed, I think, and you have selected a very good topic. And I think we are going to enlighten ourselves by the esteemed speakers. Thank you so much for giving me this opportunity. Thank you.
Thank you, ma'am. Thank you for your nice words. And definitely, as you rightly said, that this is something which is not well spoken, but which needs a lot of knowledge. And we have a great expertise in this field to share their experience, expertise, and knowledge about the infections during the pregnancy, how we have to treat them and how we have to look into them and how we have to treat both the mother and the baby, which is very important at this stage. And as you rightly pointed out, yes, this has to be talked better because we need to know much how to treat these infections in the pregnancy. So thank you, ma'am. Thank you for joining us and giving your valuable time to bless our webinar. So we have another great person here, Dr. Vidya Thobi, madam, who is the president of KASOGA. Madam is welcome you, ma'am, to be the guest of honor for this webinar. Madam is the present president of the KASOGA 23-24. She is the professor and the head of the department of Alamin Medical College, Jaipur. And she was the chairperson of the Food and Drug Medical Surgical Equipment Committee between 2018 and 20 in FOXY. And she has got the best committee award of Dr. Mehrav Dara Hanusta Award on 2020. She is the present ICOG Governing Council member between 21 and 23. She has a lot of awards from FOXY. And also she was the national corresponding editor of Jogi. And she has organized very many conferences as organizing chairperson of KSOG KASOGA 2016 and being a president of Bijapur OBGYN Society between 2009 and 2007. She was the secretary and she has published a lot of national and international conferences as in her papers and her lot of awards she has gained. And she has been a faculty for many of the university, especially the faculty for the board of Rajiv Gandhi University of Health Sciences. And she is a very, very dynamic and a very dedicated postgraduate and undergraduate teacher over the past 30 years. Madam, definitely, we are very much honored to have you with so much of experience and knowledge in this field. Thank you for joining us, ma'am. Over to you for your words of
Thank
wisdom.
you, Jairani, for those kind words. And really, I'm very much blessed to be amongst you. I think this is the second webinar I am attending of Oxy, and I always see the promising upcoming webinars, whatever you are designing, they are really great. So I am very much thankful to the team Oxy, yourself, Rajesh, and amongst all the senior stalwarts of Oxy, like Dr. Palaniappan is there, Dr. Vijay Lakshmi is there, and so many others. And today's topic, that is viral infections during pregnancy, is very dear to me. I had conducted one panel on viral infections during pregnancy, and I just saw the list of viruses. Right from the common cold we take into the day-to-day practice, we always get this every seasonal flus, and then we had a coronavirus, we had a Zika, all those viruses they affect, and they're associated with many adverse pregnancy outcomes, and include which are maternal and fetal mortality is very common. Pregnancy losses like preterm labor, then congenital anomalies. And people really ask us, fever with rash. And sometimes we are at perplexed what to do whenever the infections are there and how to treat them. So your today's webinar is so nicely designed, I must say, that there is a panel discussion, the outcome. So I really congratulate you on this very occasion of conducting this webinar, and many more to see in your tenure. I would love to listen to all the deliberations today, and definitely sometimes I may, even at the end, I may comment on the various whatever the deliberations are there. Thank you very much again for inviting me, and
Thank you, ma'am.
congratulate you for
Thank
this.
you, ma'am.
Thank you.
Thank you,
you.
ma'am.
You're
Thank you
welcome,
so
ma'am.
much,
Please
ma'am.
stay
Thank you,
with
ma'am.
us.
It's a
Yeah,
very
I will be
also,
definitely,
ma'am.
definitely, I will be staying back.
Thank you, ma'am.
Thank you, ma'am. Thank you for being here, and very special, you should say to Rajeshri.
Yeah,
Because
yeah.
she's
A
the
special
mastermind,
thanks to Rajeshri. She
mastermind
reminded
behind
me
all
at
these things.
3:55. She reminded me. So great.
She has been working a lot in this committee, and she's doing a lot of webinars and connecting with a lot of people from all over the country. Really, it's a good thing that she made everything. Thank you, Rajeshri, for
Encouragement
this
from
webinar
our
very
President and Secretary, ma'am.
Yeah. I see Dr. Palaniappan here. Namaskara. Namaste. And I invite you all for my state conference, 15th, 16th, 17th of December here in Karnataka, Bijapur. Please do. Thank you.
Thank you, ma'am. Over to Bernie.
Thank you, ma'am. So I think we'll start with our first session today, viral infections in pregnancy. Do we have an answer? So this talk is going to be given by Palaniappan sir. Sir always has answers to replicate. Sir is a professor and HOD of OBG Sri Ramchandra Medical College. He won the Elamati Javeri Award in 1994, Young Scientist Award in 1996, Dr. A.L. Mudaliar's Traveling Fellowship in 1998, Senior Overseas Fellow, Liverpool Hospitals, Sydney, Dr. Kamini A. Rao, Yuva Foxy Orator, Young Gynecologist Awardee.
Thank you very much. Respected President Oxy, Dr. Jairani, and guests of honor, Dr. Alka, Dr. Vidya, and of course Kundavi, and my dear Oxy and colleagues, and those of you who have logged in. Thank you very much for logging in, and I'm sure this topic has been chosen and given to me by none other than my great friend Rashri. Rashri, I will be sharing the slide now. Let me just see what is happening. Are you able to see my slides there?
Yes, yes.
Yes, sir.
Yeah. So here we go. And the topic you have given to me is viral infections in pregnancy. Do we have a cure? Do we have an answer? Of course, a tough question to be answered, as what Dr. Vidya did say, but then the job of the obstetrician in pregnancy is to make tough things through, and that is what we are here to, and that's what Rashri has made me do, and I will try and do this over the next 20 minutes or so. Ladies and gentlemen, I'm sure this is the virus which you're seeing on the left side, and that is God on the right side. Oh, both, do they look alike? I don't know whether they both look alike or not. At the beginning of the talk, let me have a disclaimer. I'm not supporting any religion. It's just that I got this, and we will be doing on the avatars of Krishna, and that's all, nothing else. And tomorrow I have a talk. I'm using Jesus Christ because we're going to have Christmas, and that's all, and nothing more, nothing less than that. And with that small disclaimer, let me just move on to the art of medicine consists in amusing the patient while nature cures the disease. Whether it's nature, whether it's God, or you, or me, we don't know, but we'll have to cure diseases in pregnancy and infections in pregnancy. Viruses are the simplest of the living organisms, but have significantly compound, one of the most causative factor for infectious diseases, whether it's being common cold, flu, etc., etc. Initiated by the virus binding to a specific host receptor cell, viruses must enter the cell, replicate their genome, and release infectious virions. And the outcome of it depends on a lot of factors like the host factor, the age, the immune status, and of course the nutritional status of the particular patient. The avatara of whatever is Matsya avatara, which may not be related to, that's one of the avatars of Lord Vishnu, and we will be dealing with 10 viruses today, and that is what we will deal with as Dashavatara, and that's exactly the theme of today's topic. I will not go into Hindu mythology. First is the HIV during pregnancy, one of the very, very common and one of the most flaunted viral infections which we had or which we still have, but we brought them probably into control. Do we have answers for HIV positive pregnancy? Yes, initial evaluation, hepatitis B serology you will do, whether it is A, B, C, whatever. Hepatitis C screening to be done because they can be coexistent and complex metabolic panel, including your aminotransferase levels. STD infections for syphilis, chlamydia needs to be ruled out when you have an HIV positive pregnancy. And when you have a HIV positive pregnancy, you'll do a plasma HIV RNA assess at the initial visit, then 2 to 4 weeks after initiating or putting her on an antiretroviral therapy monthly until the RNA levels are undetectable, then at least every 3 months during pregnancy. Your HIV RNA levels also should be assessed at near term so that to confirm recommendations regarding mode of delivery and optimal treatment of the newborn. And what was not done some time back and which is now very easily available is your exactly the CD4 count, which is, we will see that the next few slides. You assess at the initial antenatal visit and at every 3 to 6 months, if not every 2 months definitely during pregnancy. Less frequent monitoring is appropriate in patients with undetectable viral load and CD4 counts well above the threshold for opportunistic infection risk. You will also think in terms of HIV drug resistance studies, which should be performed prior to initiating or modifying your ART in women with the HIV RNA levels. Above the threshold, we will come back to the levels, maybe between 500 to 1,000 copies per ml, unless they have been recently tested and they have ARV resistance. An early ultrasound to confirm pregnancy, dating, gestational age is mandatory to guide timing of scheduling a cesarean delivery if necessary. I'm not saying you should do cesarean delivery, and you will do a glucose tolerance test on the basis of whatever. And here we do at booking and then again at 24 weeks for whatever. Coming to the interval of testing, monitoring of HIV in pregnancy, we will do a viral load testing monthly every 2 to 4 weeks on initiation of treatment and space out later because we need to know the progress and efficacy of the disease. And you will do an LFT and RFT weekly at the onset of treatment and then spaced out when stable to know the effect of the ARV on the drug and ARV on the body, and of course on the target organs, the liver and the kidney. A reason to detect early liver disease and whether you have a cytotoxic effect secondary to the drugs, and we'll do a full blood count every month, keeping in mind the hemoglobin and the platelet value so that we have an idea that the marrow is not suppressed by your ART regimen, and you will do a CD4 count every 3 months minimum to know the progression of the disease. And these, whatever I'm going to talk to you today, are very recent recommendations, maybe a couple of years back. Coming to the main investigations, apart from what I said, we need to think in terms of the viral load of less than 50 HIV RNA copies per ml is something which we need to keep in mind. And then how do you treat them? The only ART licensed for use in pregnancy is Zidovudin in your 3rd trimester. But we need to understand that if they are not on a combined ART, continue the same throughout and then lifelong. Probably try monotherapy with your protease inhibitors. And what you can do about the delivery planning is assess the HIV RNA load at 34 to 36 weeks of gestational age. The HIV RNA load is more than 1,000 is what I told you. LSCS at 38 complete weeks of gestation. And now we need to understand that if your viral RNA load is less than 1,000 copies per ml, oh, you are not wrong in giving a vaginal delivery. Please understand the point. When we were all students, we were taught HIV, don't infect the vagina, don't deliver them vaginally or do a cesarean section. But that's not the idea. Now you will do a cesarean section only if the viral load is more and the viral load is less than 1,000. You are allowed to do a vaginal delivery because that has the least risk of maternal morbidity and, of course, mortality. Elective CS has intermittent risk and emergency CS has the highest risk. And so we need to think in terms of doing a vaginal delivery by all possible means for a patient with HIV positive pregnancy, provided you don't have obstetric indication to a cesarean section. Normal delivery with a plasma viral load of less than 50 HIV RNA copies per ml at 36 weeks in cesarean section if the load is more than 400 at 36 weeks. So you can take into consideration your HIV copy mode or your RNA copy modes and then think in terms of delivering them vaginally or by cesarean section according to the load. So HIV positivity does not mean that you need to do a C-section at all. It depends on the next factor, that is the load. Vertical transmission is less than 0.5% in a woman with a viral load of less than 50 for which you will do a vaginal delivery. Management of labor and delivery previously avoided. Ladies and gentlemen, please understand that we did not do an ARM, we did not do fetal scalp elements, we did not do a fetal blood sampling, we did not do operative vaginal delivery, we did not do an episiotomy for HIV positive patient. But now please understand that all of them are changed and all of them are allowed now, provided the patient is on a combined ART regimen and the viral load is less than 50. Intrapartum therapy. Sometime back, we were asked to give IV Zidovudin. IV Zidovudin is no longer required for women receiving ART regimens with a load of less than 50. So let me again tell you again and again, your management will totally depend upon the HIV load of less than 50 or more near delivery. And that's what we need to keep in mind. The intrapartum IV Zidovudin no longer recommended to be considered only if the load is more than 1,000 or the viral load is not known. And breastfeeding, the risk of HIV transmission through breast milk for a woman on CART is 1.08% at 6 months and 2.4 at 12 months. And so WHO recommends exclusive breastfeeding and then complementary feeding after that. And so we go on like anything. And so a lot of things have changed over your HIV management in pregnancy. Having finished HIV, we have the Kurmavatara, which is the tortoise, which just goes under and above, lives in the land and sea. And I'm sure we had the corona all over the arena. I'm not going to touch corona because we've had enough of that. And my time limit will not accept that. So we will not deal coronavirus. Just to touch upon, we had enough of it over the last 3 years. Varahavatara, the boar which could bore on everything. And let's understand that influenza was a boring virus which just struck again and again and again. And we need to understand that do we have medications for influenza? Of course, we have enough medications for influenza A and B. The drug of choice, probably, this is all what I'm talking of in pregnancy, or you can still give oseltamivir for influenza A and B, and you have the NA inhibitor here. All of them are NA inhibitors, and you would use them for treatment and for prophylaxis at a dose of 75 milligrams twice daily for 5 days if it's going to be for treatment, and 7 to 10 days if it's for prophylaxis, and there are no contraindications at all. The rest of the two drugs, the Rabivab and the Zanamivir, are used as second-line drugs, and the drug which we use are oseltamivir, and that's what the virologist or the infection disease consultant would be quite fond of using. Women suspected to be infected with influenza should be treated with immediately, independent of their vaccination status, without waiting for diagnostic confirmation. The recommended treatment, as I told you, are the first two drugs. Acetaminophen should be used as an antipyretic to prevent maternal influenza infection associated with perinatal morbidity and mortality. Both the ACOG and the CDC recommend that all women, whatever will be pregnant during influenza season, October to May, will receive an intramuscular inactivated vaccine so as it is available ideally prior to, and this is the time you take the vaccine. And the intranasal vaccine contains live attenuated virus and should not be used during pregnancy. So you would go ahead the intramuscular vaccine, and it is some hospitals follow it as a routine protocol to go ahead and give all pregnant patients the vaccine. Coming back to Narasimha Avatara, half man and half lion, I'm sure you know the Avatara, very powerful. And this virus, though not very powerful, but can be quite common as it's quite common. And this infection, this virus infectiosum can be presenting to the baby with a slack cheek appearance. Fetal infection can be asymptomatic, and that's what I said, it can be present but still not be present, or can cause an aplastic anemia leading to high output congestive cardiac failure and NIH. Serial ultrasound with the middle cerebral artery PSV, just like what you do for your Rh negative pregnancies, are recommended every 1 to 2 weeks for 8 to 10 weeks following your maternal infection. Fetal infection occurs following approximately 33% of maternal infections, and we need to think in terms of chordocentesis and intrauterine transfusion with the help of a fetal medicine specialist are recommended treatment options for parvovirus infection. And coming to the dwarf, the smallest of the avataras, the virus is not a dwarf. The virus is quite an active, tall virus, the measles virus, the most infectious. Upon exposure, 75 to 90% of susceptible contacts become infected. Please get the point. Upon exposure, 90% of susceptible contacts become infected. So what I want to tell you is the most infectious virus. 60% of them require hospital admission. 26% will acquire a pneumonia, 3% of them will die due to a complication. That means 100, 3 of them will die because of a pneumonia or whatever. 20 to 60% of them will have a risk of spontaneous abortion, and most effective ways to prevent rather than cure by an MMR vaccination. An MMR vaccination, I'm sure, is very, very popular amongst the pediatricians and infectious disease consultants. And so we need to think in terms of vaccinating them rather than having the disease and then getting treated. Vaccine not for pregnant women, and contraception for 3 months post-vaccination, no doubt about it. And treatment with IV immunoglobulin, 400 milligrams per kilogram within 6 days of the exposure, and treat them symptomatically. What I mean is give them paracetamol, IV fluids, whatever, vomiting you give, antiemetics, and go on. And during pregnancy, we don't have treatment. So this is most probably a disease which is to be prevented rather than to be treated. Coming to the Parashurama Avatara, the Brahmin warrior, quite powerful and effective. Of course, the rubella vaccine, which we need to keep in mind always. A congenital rubella will produce a miscarriage or a stillbirth, miscarriage in first and second trimesters, and a stillbirth in third trimester, which we always need to think about when we have a recurrent pregnancy, loss, and stillbirth. IV immunoglobulin does not prevent congenital rubella infection, although live attenuated vaccine is contraindicated during pregnancy. There are no reported cases of congenital rubella syndrome in 1,000 infants born following inadvertent vaccination during pregnancy. So I'm not telling you need to go and vaccinate pregnant women for rubella. The idea is to say that please vaccinate them prior to pregnancy. That's the exact what I'm trying to say. Coming to the next avatar, the Rama avatar, or the most flaunted warrior prince, or the most handsome avatara, we have the herpes virus, not very uncommon in pregnancy. We do have treatment options for the herpes virus during pregnancy. Oral regimens are available for herpes simplex during pregnancy. The first episode of genital herpes simplex, the drug of choice is either acyclovir, and now we have moved slowly to valcyclovir. Acyclovir being 200 milligrams 5 times a day, or 400 milligrams 3 times daily. Valcyclovir 1000 milligrams twice a day, and you would go on to 7 to 10 days. The primary non-first episode or recurrent genital episode, the secondary episode, we need to think in terms of a higher dose of acyclovir and valcyclovir both, and you give it for 5 days. You want to suppress HSV, probably you give 400 milligram 3 times daily and 500 milligram of valsiclovir twice daily from 36 weeks onwards of gestation until delivery. So that's what we need to do if you think in terms of a recurrent infection in pregnancy and suppress the virus from getting infecting the fetus during labor. We need to think in terms of giving her from 36 weeks to till delivery whenever you want to deliver her. And this recommendation taken after so many evidence-based materials and from the ACOG practice bulletin. Herpes virus treatment, of course, as I said, you would give acyclovir, valsiclovir, and the next drug in line would be the famciclovir. ACOG recommends elective cesarean section, demonstrable genital herpes lesions. Get the point clear? If there are genital lesions active during labor, you could go ahead and do an elective cesarean section. If not, you could think in terms of doing a vaginal delivery if the lesions are not very active. Non-genital maternal HSV lesions, valsiclovir can be given, and cesarean section is not recommended if the infections are not in the genital area, and we need to be quite cautious about delivering the patient by C-section, taking your universal precautions for spread. Coming to the Krishna Avatara, the cowherd wherever he flutes and he goes around and we follow him, or we have the chickenpox virus, which is quite common and was very common over the last 2 or 3 months back. Do we have a cure for chickenpox in pregnancy? Oral acyclovir, just we finished for the herpes simplex, 800 milligrams by mouth for 5 times per day, or valsiclovir 1 gram by mouth 3 times a day is quite safe in pregnancy. It decreases the illness duration if instituted within 24 hours of rash appearance and should be given to all infected women. You don't have to think twice whether she needs acyclovir or not. Straight away go ahead and give immaterial of whether it is the first trimester, second trimester, or third trimester. If it occurs within 5 days before and 2 days after the delivery, we need to think in terms of varicella zoster immunoglobulin to be given to the newborn to prevent a neonatal varicella zoster. Prevention includes ascertaining varicella zoster vaccine status prior to pregnancy in women without a clinical history of infection and offering a live attenuated varicella vaccine to susceptible women prior to conception. So it is definitely a vaccination to be thought of, because it's quite dangerous to have a varicella infection in pregnancy. Live vaccine is contraindicated during gestation. Pregnancy should be deferred for 3 months following vaccination, although there is no evidence of congenital varicella zoster infection following a vaccination during pregnancy. But a confirmed varicella zoster susceptibility or the inability to obtain serology within 96 hours of exposure, the preferred prophylaxis is high titer varicella zoster immunoglobulin. Coming to the Buddha or the saint or the sage Balarama Avadara, what is the virus which is going to say? The virus is hepatitis B, who will always be within the liver. No, it is not like that. It takes a longer course and remains forever as Buddhism. And that is about the hepatitis B virus. It's a recombinant vaccine, what is quite safe in pregnancy and should be offered to patients with significant risk factors of sexual transmitted disease, healthcare workers, and those with infected household. So this is again a virus which is to be prevented rather than treated during pregnancy. Therapy would include lamivudine, tenofovir, and they have been tried quite well, and there are no contraindication to breastfeeding when you have a hepatitis B positive patient. And coming to the last of the avatar, the Kalki avatar of the HPV vaccine, what do we do when we have a HPV infection in the pregnant patient? You could, what? That's what I mean, a what? Trichloroacetic acid or a cryotherapy once used to treat anogenital warts in pregnancy as podophyllin is contraindicated. And so we could give a trichloroacetic acid. And here definitely the vaginal delivery is contraindicated, no doubt about it. We need to probably think in terms of doing a C-section. So now we go ahead and think in terms of summary. This is a chart which I've just summarized the entire thing. What is the infection and which happens to the mother and the baby, and what can you do about it of all the viruses which we spoke of. And I'm sure it's going to be available as a recording, and I will not read through the entire thing because that's going to be the concluding slide. And we go through all the viruses, including the Zika, the Epstein-Barr, and the Ebola, which I have not dealt in detail because that they are not that very common except on an episodic prevalence. So we don't see that as a very common infection. And here are the recommended vaccination during pregnancy, universally recommended, acceptable if indicated, and contraindicated would be what? This is on a tabular column. Definitely recommended is influenza, TT or TD now, and with the acellular, but Tdap is what we give now. And I'm not going to talk to you on vaccination alone, only pertaining to viral infections we will deal with. And acceptable if indicated, you would go ahead and give a hepatitis A, hepatitis B, inactivated polio, meningococcal, pneumococcal, rabies, and yellow fever. And the vaccines which are definitely contraindicated, viral vaccines, are your live attenuated influenza, that is the intranasal vaccine, your MMR, your oral polio virus vaccine, and your varicella and smallpox vaccine are definitely contraindicated in pregnancy. And the cure for anything is salt water, sweat, tears, or the sea. Having finished the Dasavatara, I'm sure whenever you have a huge viral load, you will always have a sea of treatment, which we have seen over the last few years. And this is something which you can listen to the video for only 1 minute, and that is the movie Dashavatara. Oh, ladies and gentlemen, that was a scene from the tsunami last climax scene of Dashavatara, where a bunch of salt water could kill a huge load of virus. And so the answer to is that whether it's God, you, or me, we are here to treat viral infections in pregnancy. And thank you very much. Appreciate question and answers.
Thank you very much, sir, for that.
As of now,
Blow
there
by
were no
blow
questions,
detail.
but you stay on, Dr. Paini. Thank you so much. Thank you. I mean, our first one started off well. You've kick-started the webinar so well, and always expected of you. And yes, you have delivered as usual wonderfully. Thank you.
Thank you very much.
Shall we move on to the next? I don't see any question and answers. Any of you, do you have any questions? We have given 10 minutes for the question and answer session. Bharani, we'll move on. We'll see the next one.
Okay, ma'am. So after that rousing start, we'll move on to our next talk, which is non-viral infections. We're trying to understand non-viral infections, and we have Dr. Vijayalakshmi Balakrishnan ma'am, who's going to give us this talk. She's a graduate of Stanley and Madras Medical College. She's done her training in infectious diseases from Christian Medical College, Vellore. She's head of the department and senior consultant infectious diseases, Kaveri Hospitals and SIMS Hospitals, Chennai. Director of Preventive Health Digital Health Platform. She's doing Executive MBA in Healthcare at Indian School of Business. Power Women Award in Infectious Diseases and Healthcare in 2021. Mayan COVID Warrior Award 2021. And she's a public speaker and publication in medical and non-medical journals. We're very happy to have you, ma'am. Over to you.
Good afternoon, everybody. Thanks for the, just a minute. Slides. Down PowerPoint. Just a minute. We are going to talk about non-bacterial infections. Non-viral infections now. After a heavy session, this is going to be something light. I'm taken up real life scenarios. And just given a framework of how to go. And just one small problem with the connection. Just give me a few minutes. It's time. Am I audible?
Yes, ma'am.
Just 1 minute. Is my screen visible?
No, Viji, you are not sharing it yet.
Okay.
You're not sharing your screen.
I'm just sharing it again.
Yes, you have started sharing. Yes, Viji.
Yeah, sorry. Just 1 minute. Okay. So next 15 or 20 minutes, am I audible? Shall we go ahead?
A little louder. You should come closer to the.
Yeah. Am I audible now?
Yes, Viji.
Okay. So next 15 or 20 minutes, we're going to discuss about non-viral cause of fever. Here, I'm going to give you a framework about handling an infection, and then we'll go ahead about handling it. So when we talk about fever, everybody thinks it's an infection, and everybody thinks it has to be treated with antibiotics. Just now, we had an excellent session by Dr. Paniyappan, who spoke to us on viral infection, none of which requires antibiotics. We realize that majority of infections are actually viral and they don't require any treatment at all. Going ahead, when we talk about fever, fever just is a manifestation of something which is disrupting the harmony, and it requires antipyretics, and antibiotics treat bugs. They are not antipyretics and they're not going to have a direct effect. So when we talk about infections, we divide into two things. One is undifferentiated fevers and fevers which have localization. And fevers which have localization. When I say undifferentiated, you're talking about all the tropical fevers like malaria, enteric fever, leptospirosis, scrub, dengue, hanta, viral, bacterial, parasitic, all these things are undifferentiated fevers. And it differs from area to area. For example, post-rainy season, we do see some melioidosis. And if you go to some areas, you can have things like penicilliosis. These are all local endemic infections. Next comes fevers which have a syndromic localization. Let's say somebody comes with fever and cough, then you think about respiratory infection. Somebody comes with fever and diarrhea, you're thinking of a GI syndrome. Somebody has urinary symptoms and you think about genitourinary. This kind of syndromic classification is very important because that will bring us to decide about the etiology and further treatment. Let's go back to the undifferentiated fevers. What are the undifferentiated fevers we have in Tamil Nadu now, especially in Chennai? So you are having malaria. Yes, we do see malaria. Enteric fever, we see round the clock. Lepto in patches. So now we don't see much of leptospirosis in Chennai. All of us have become a kind of responded to it. Scrub typhus during the post-rainy seasons. Dengue, chikungunya, hanta, all these are seen during seasons. Now, how do we diagnose them? You get an examination, look for a rash, look for an Heshkar, leptosplenomegaly, purpura, etc., etc. And when you talk about investigation, malaria can be easily picked up by MPQBC. So MPQBC being negative twice or thrice essentially rules out malaria. Thinking about counts help us to decide about a lot of viral etiologies. And then when you're talking about serology, delay it. Somebody comes on third day or fourth day with a crashing. You think about scrub typhus, don't send the serology. Serology will be negative. Obviously, by the time it will be positive, it will be 1 week. So at that point of time, you rather start the treatment, wait, and then do a serology rather than decide based upon the serology. The only serology which can be done earlier is dengue fever. Why do we do blood cultures for these kind of undifferentiated fever? The simple answer is typhoid is diagnosed by blood culture. In this era, there is no role for serological diagnosis of typhoid fever. Your Vidal test is obsolete. It is gone 20 years back. False positive and false negative rates are extremely high. So going on to the issue of pregnancy, you will realize some of the infections can present with very serious manifestation during pregnancy. Some, only during pregnancy, they are pathogenic. If you look into the order, majority seems to be viral. CMV, rubella, parvo, influenza, chickenpox, dengue, everything is viral. We have very few bacterial infections presenting with undue severity during pregnancy. There are some bacterial infections which are seen during pregnancy like Chroria amniotis, which are all specifically bacterial. So going on to somebody coming with fever, how do? You have to think about asking for the duration of fever. A short duration illness, the differentials are different from a long duration illness. So this session, it's only a 20-minute session. I'm going to talk about only somewhere between short and medium level. We are not talking about long-term fevers. Obviously, it's an antenatal women. You're not expecting somebody who's been having fever for 3 months to become pregnant. So if you're looking at patient who's pregnant coming with fever, so our fever duration will probably be around 2 to 4 weeks. That's what we're looking at. Do they have a localizing symptom? The importance of localizing symptom is this will differentiate undifferentiated fevers and fevers with syndrome-specific fevers. And that will give us a clinical diagnosis. Once we have a clinical diagnosis, we need to go for a microbiological and pathological diagnosis. We have a syndrome. Next, we have to think about what bugs can cause it. Like, for example, somebody comes with fever and cough. You have to think about if it's going to be respiratory syndrome. What can produce respiratory syndrome? Say the viral or some gram-positive organism like pneumococci, staphylococci, etc. So if it's going to be viral, what will be the drug test of choice? It will be PCRs. If it is bacterial, you're thinking of sputum cultures. And if it is viral, probably things like oseltamivir if it's flu. If it's bacterial, appropriate antibiotics. Again, if it's a pregnant woman, no other problems, you will be treating only for gram-positive bugs. You're not going to get E. coli causing a pneumonia in a pregnant woman. Investigation, and then if you're suspecting sepsis, start empirical therapy as soon as you diagnose sepsis. Don't wait for the cultures to come. Once the cultures come, you can adjust the antibiotic and make it definitive therapy. So let's come to the common infections in pregnancy. Seasonal fevers. Your dengue, chikungunyas, malaria, and scrub typhus around this period. Endemic fevers, you see them throughout the year. Typhoid fever is something which we see in pregnant and non-pregnant women throughout the year. Two other common infections we do during pregnancy is urinary tract infection, respiratory infections. All others are relatively uncommon. We have an excellent panel discussion subsequently where we'll again be covering about certain infections. I've just put on scenarios which is not covered there. So I'm just putting two scenarios to get us through how to diagnose an infection. So this is first case is a young lady, would say middle-aged lady, 35. So fourth pregnancy with one abortion, third trimester. She's been treated for fever for almost a month. Recently been admitted. Somebody says it's UTI. They had given her oral third generation cephalosporins. The cefixime 200 BD. She's been on it for more than a week. Then stopped. Then she was given something else. So this has been going on for nearly a month and she comes to you. She's off antibiotics for 3-4 days. On examination, she's afebrile, normal. She has been treated as UTI outside. So when she comes to OPD, you know it's a subacute illness. It's 1 month. She could have had a urinary syndrome. If it's a prolonged course, what do you think about a urinary infection which is there for 1 month? You think about a structural issue, whether there's an obstruction, whether she's got an abscess. Is it a resistant bug which is partially treated? Has she seeded the cardiovascular system from the urinary tract? Is that why she's causing it? Usually, gram-negative bugs cause it. Coliforms are the cause. But at this point of time, think again. Could this be something else? At this point of time, we don't know. So, investigation, what she had in hand is urine routine showing 12 to 15 pus cells and urine culture showing E. coli with 10 power 5 colonies. Resistant to third generation cephalosporins, sensitive to piptas, cefazole, carbapenem, zamicas, and nitrofurantoin. With history of fever for 1 month. So let's assume this is UTI. How do you treat it? So at this point of time, we know it is resistant to third generation cephalosporin, which means your ceftriaxone, cefotaxim's out. It's resistant to cotrimoxazole, which are not giving. Fluoroquinolones, anyway, we don't give it during pregnancy. It is sensitive to piperacillin, tazobactam, beta-lactam lactamase inhibitors, carbapenems, amikacin, and nitrofurantoin. We don't give amikacin because it is again a class T drug. What about nitrofurantoin? Nitrofurantoin will come back again. So here it will be a beta-lactam lactamase inhibitor or a carbapenem, which is like ertapenem will be the drug of choice if we are assuming UTI. Nitrofurantoin and fosfomycin are used for cystitis. You can't use them for pyelonephritis because they don't get concentrated in the kidneys. If it is going to be asymptomatic bacteriuria, you treat it for 7 days. In pregnancy, a pyelonephritis is anywhere between 7 to 14 days of antibiotics. Now, this brings it to an important question of asymptomatic bacteriuria because I often get patients referred to me for that. But remember, asymptomatic bacteriuria means 2 cultures have to be positive, the same organism with a significant colony count. Because there is something called as transient bacteriuria, where you can have a bug in the urine transiently and 10% of us will have it. And picking that up will be increased unnecessary treatment. What about nitrofurantoin? Can you give it for asymptomatic bacteriuria? Yes. Can you give it for cystitis? Yes. But can you give it for pyelonephritis? No. Second, during the peripartum period, near delivery, avoid this because it can lead to neonatal hyperbilirubinemia. So let's come back to a patient. We have discussed about UTIs. This, we go back to the history because at this point of time, we are not sure. When you ask her, she says she's got an urgency. She passes urine frequently, and this has been there for nearly 2 weeks now. There is no pain on urination. She's got some white discharge. This is the history. Her main problem is stress incontinence. Whenever she coughs and whenever she has an urgency to pass urine, she can't walk to the toilet. She kinds of wets her panties, and that really worries her. And that's why this thing of UTI came up again and again. Now, the question is this UTI? 10 to 12 to 15 pus cells, white discharge. There is a history of fever. So do you call it white UTI? Is it any tropical fever? 1 month history. Can it be tuberculosis? Can it be a chorioamnitis? So baby ultrasound wise is normal. Baby's heartbeat is good. Baby looks good. Now we know these are the possibilities. Now what investigations to be sent? CBC, RFT, LFT, I guess everybody will agree. These are the basics. She had not done it. Would you want an MPQBC here? Malaria, 1 month fever. So it's not been a high grade fever. There is nothing to suggest jaundice. She is not. So malaria is unlikely, but as a routine, if you want, you can do it. So can you think about tuberculosis, X-ray chest, CT chest? Again, no cough. A pulmonary tuberculosis without cough is almost impossible. So we can essentially rule out. Ultrasound abdomen, yes, to see whether there is an obstruction in the urinary symptom. Do we need a CT abdomen? No, we are not thinking in terms of something like an emphysematous pyelonephritis. Serology, lepto, scrub, can they survive for a month with fever? Very unlikely. Finally comes blood cultures. Do we do blood cultures, and why do we do it? Are we suspecting a bacterial sepsis? Here, I want it for few other purposes. So what I did was, we sent a CBC, we sent a RFT, LFT, we sent an MPQBC, we did an ultrasound abdomen, we did blood cultures. And then this is what the count says. Total counts 8,600. Differentials are 55% neutrophils, lymphocytes 35%, monocytes 10%. Platelets 1.5 lakhs and hemoglobin of 9.8. And blood culture after 3 days came out to be Salmonella paratyphi. This lady basically had urgency during the 3rd trimester. As the baby became big, the bladder got pushed, and she's been having frequent urination. And there's not been any pain. There is some white discharge and nothing beyond that. And that's assumed to be UTI, and received antibiotics. She had received nitrofurantoin. She had received all the only reason the culture picked it up was the dose she received was very small. She was a huge lady, somewhere around 80 kgs, and she received 200 mg BD of cefixime. Otherwise, cultures would be negative and we would be breaking our head. So we put her on 3rd generation cephalosporins, ceftriaxone or cefotaxime. Other options will be azithromycin. Cotrimoxazole, again, I would avoid it towards the end of 10. She said most 36 weeks. So she settled with this treatment. Next comes, we'll finish off with complicated UTI in pregnancy. We often see complicated UTI during pregnancy. Pregnant patient coming with obstructive uropathy, pregnant patient with calculuses, renal abscesses, resistant infection. All these required a prolonged treatment. You will go for high-end antibiotics and treatment is individualized. And remember, all these should have a microbiological diagnosis, not just a structural diagnosis. You cannot treat something as a renal abscess without the culture being positive, which is unusual. Same thing applies with resistant infection. Just because somebody has fever, don't start going from augmentin to ceftriaxone to Perazone sulbactam to meropenem to ceftazidime avibactam. It doesn't work that way. If somebody has a resistant bug, culture will grow. Send off cultures and then start a treatment. So that brings us to this scenario. What started off as UTI turned out to be enteric fever. I'll have one more short scenario before I finish up. This is another scenario. Young lady, antenatal, almost second trimester, with fever followed by altered sensorium for 2 days. Treated with IV antibiotic for 3 days. She's been having fever. She's neck stiffness is there. There is mild icterus. Comes to the ER and one of those centers where LP gets done immediately. So LP happened immediately. So because at that point of time, it is fever with altered sensorium. So you assume CNS infection. And then other tests were done. Some CSF results brought in immediately. It was 100 cells, 80 protein, sugar of 55 with CSF smears being negative. Does it ring a bell? So generally, if it's going to be a pyogenic meningitis, I expect high counts with lot of neutrophils. We expect the protein to be very high and sugar to be very low. Counts are marginally elevated. Protein is marginally elevated. Sugar seems to be bang on normal. That's confusing. This doesn't look like a bacterial meningitis. Could it be a partially treated pyogenic meningitis? Only 3 days of antibiotic. Tuberculous meningitis, history is acute, very unlikely. Can it be viral meningitis? Yes. So at that point of time, the thought was whether it is a viral meningitis. By then, the other investigations came in. Hemoglobin of 9, platelets of 90,000, MPQBC negative, creat is elevated, there is hepatitis. And she became sick, she had to be put on a ventilator. So basically, she's got fever with multi-organ dysfunction. Fever, altered sensorium, so encephalopathy to encephalitis to meningitis, kidney injury, liver injury, ARDS, and probable coagulopathy. So this is fever with multi-organ dysfunction. Basically, it's an undifferentiated sepsis with multi-organ dysfunction. Because it was altered sensorium, we pinged upon meningitis. As usual, our first diagnosis was not right. So what could it be? Could it be malaria? Could it be leptospirosis? Dengue, Hanta producing encephalitis, rickettsial illnesses. Think about malaria. Malaria producing CNS malaria seems to be very common, especially in Tamil Nadu now. Patients do come in sick, they can present this way, but these MPQBC is usually positive. Leptospirosis, as MODS, I had seen as my undergraduate. Chennai seemed to have grown out of leptospirosis. All our serologies will be positive, but we hardly see sick ones. Hanta takes a longer time. Dengue encephalitis is fine, but dengue presenting with MODS is unlikely. That brings us to rickettsial illnesses. What she had was scrub typhus, and this is a classical edge scar. And you see it either in the armpit or probably at the end of the panties, because these bugs climb up and where they have a restriction, they stop there. And that's where the edge scar comes. So basically, it's an acute febrile illness. They can have any kind of rash, an edge scar. They can have purpuric rash, diffuse rash, usually have a multi-organ involvement. Thrombocytopenia is seen in majority of cases. The counts can be normal, raised, or decreased. Majority will have some hepatitis. And the ELISA is positive after a week. Usually, what they produce is a vasculitis. So because of the vasculitis, multiple organs get involved. This is another variant where it's not scrub typhus, it's a spotted fever caused by rickettsia. It produces more like a purpuric fever, high-grade fever, hemorrhagic manifestation in the limbs, patient coming with multi-organ infection. Remember, it's all acute. So when they come to you, you cannot have a definitive diagnosis. Definitive diagnosis, serological, takes a longer time. Treatment of choice is doxycycline. When the patient is relatively stable, you can go for azithromycin. When a patient is as sick as this lady, you will have to go for IV doxycycline with IV azithromycin. Here, the patient's life has much more importance than anything else. So this lady, we will giving IV hydroxycycline 100 mg BD along with IV azithromycin 1 gram IV OD. She recovered and she got discharged. So this is the mite. It is seen during rainy season in shrubs, small shrubs. And the bite is painless, so nobody notices it. And then it's also in the areas where you don't really look. So under your braziers, behind in the neck, axilla, under the panty liners, that kind of an area. So scrub typhus, India's endemic scrub typhus, we see it every year during the rainy season. This year also we've been seeing it. So common things are commoner. So always think about what is there in your community before thinking about bizarre diagnosis. So bringing that, finally coming to the antibiotic usage, always try to go for B or C because A category hardly exists. And remember, a small proportion of birth defects can be chemically induced, and that can be because of the drugs you give. So always be careful with that. The exposure depends upon the exposure, and the fetal age manages the most. So if you're going to give it around the time of organogenesis, the outcome is going to be bad. Take-home messages: fever has a huge spectrum. Common things are commoner. Have a syndromic diagnosis, followed by a microbiological diagnosis, then go for a therapeutic. Don't forget blood cultures. Don't do serology early. Serologies are always after a week. And again, finally, hand washing is what is going to benefit us the most. If you're thinking of bacterial infection, if you're thinking of patients in your ICU, in the wards, hand washing helps us the most. And thanking Semelvis, I end the lecture. Thank you.
Thank you so much, ma'am, for that exhaustive talk and very precise take-home messages. We take question answers. Are there any questions from any of the audience?
Either everything was clear or everything was hazy.
I don't see
We don't have any
chat box right now. It was precise, it was clear, concise.
Yeah.
Thank you, ma'am. We don't see any questions in the chat box. Maybe people can keep putting in their questions. We'll probably take it after the panel discussion, ma'am. Can we move on with the session? So moving on, we're going to go to the next most awaited session, which is a panel discussion. Sepsis is an insult to a surgeon, they say. And it's also quite daunting to treat. So we're going to have a panel discussion where we're going to unveil sepsis and navigating through sepsis in pregnancy and postpartum. We have Dr. Kalevani ma'am, who's going to be the moderator. Madam is the director of Institute of Obstetrics and Gynecology, UGPG teacher for the past 25 years. Special interest. She's conducted workshops on basic obstetric skills and emergency obstetric skills in various forums. Special prizes and achievements. Best Doctor Award by Tamil Nadu MGR Medical University for the year 2018. She is the chairman board of studies of PG in Tamil Nadu Dr. MGR Medical University and executive committee member in OXY. Welcome, ma'am. And she's got a very eminent set of panelists today. Dr. Mangalatita, ma'am. She's professor in IUG, graduated at Keelpok Medical College, post-graduation from MMC, DNB, she's done her DNB, MBA in Health Sciences Management at Anna University, Guindy. She's got more than 23 years of teaching experience for undergraduate and postgraduate students. Welcome, ma'am. Dr. Preeti G. Singamani, she's a UG from Chengalpet Medical College, best outgoing student in general medicine, and she did her DGO and MS from MMC. She's presently assistant professor at ISO KGH KKK. She's been in Tamil Nadu government service for the past 15 years, been in public health and medical service directorates with unblemished service and quality cum quantity track records. Best Doctorate Award for family welfare performances in Tanjavur and Tiruvallur district. Interested in UGPG academics. She's been an active part of Tanjavur pilot projects and CA service screening program with success stories that later paved way for screening in the state. She's passionate about OBGYN and continues to learn just like all of us. Welcome, ma'am. Dr. Vidya Jayashree, ma'am. She's MBBS from Madras Medical College, DGO from Madras Medical College, and MSOG from Stanley. Worked in state-of-art fertility center in Tamil Nadu government service for more than 15 years now, assistant surgeon in ESI hospital. Currently, she's a senior assistant professor at IUG MMC. She's published papers in national journals, and her field of interest is laparoscopy, infertility, gynec-oncology, of course, UGPG teaching. Welcome, ma'am. Our next panelist, Dr. Vijayalakshmi Sheshadri, ma'am. Ma'am is a senior consultant at Sundaram Medical Foundation, Chennai, President OXY 2021, past executive committee member TNFOG, Constitution Committee member ISOPRAV, member for OXY Practical Obstetrics Committee, past quiz committee member IMS, chairperson research committee IMS from 2018 to 2020, past chapter secretary Chennai IMS, Treasurer AICOG 2015, Asia GCC Women Healthcare Leader Award in 2021, Best Paper Award in AICOG 2014, ICOG's Valued Contribution Award in 2021. She's got a special interest in high-risk obstetrics, midlife health, and medical law. Welcome you, ma'am. Dr. Angeline Selvaraj, Super Specialist Consultant in Plastic Surgery and Burns, ESIC Medical College Hospital, KK Nagar, Chennai. She's retired as Professor in Plastic Surgery from KMC. MBBS from Madurai Medical College, MS General Surgery from Madurai Medical College, and MCH from Keelpop Medical College. She's a life member of Association on Plastic Surgeons of India, NABI, International Society of Aerospace, Association of Plastic Surgeons, Tamil Nadu and Pondicherry. She's a DGCA authorized Class 2 medical examiner for pilots, and she's got a successful unblemished government medical service in Tamil Nadu for 32 years. We welcome you, ma'am. Dr. M. Prabhu, around 20 years of experience in intensive care, and he's at present working in Sundara Medical Foundation for the past 10 years. We welcome you, sir. And Dr. Vijayalakshmi Balakrishnan, ma'am, who gave us such a vivid talk now. We welcome you to the panel as well, ma'am. Over to you, Kalaivani, ma'am.
Thank you. Thank you, Bharani, for that kind introduction of me and my panelists. We will now move on to the session proper, sepsis unveiled. We will be dealing only with septic cases which we have dealt during pregnancy. Shall I share my screen? 1 minute.
Shall I share?
Sure. Madam, is it seen? Is the screen seen?
No.
Not
Your
yet,
screen
ma'am.
is seen, Kala, your screen is seen, but you have to open yours and keep it down, no? And open that alone. Before you...
Now it is seen on my screen.
No.
Kala,
Kala,
I have opened it.
Go back again.
Okay.
They open the topic that sepsis unveiled PPT is there, no?
Yeah.
Just take it, open it, make it small, and then you share screen and you open that. You always have to open it and keep it down. Minimize it and keep it, and then take it. Okay. Minimize it and keep it, then share screen and open it.
Okay. 1 minute. It is on the desktop. I minimized in the desktop. I'll open it.
Now you share screen and open it. Okay. That should already be opened before you share the screen.
Okay.
Only then it will open.
Okay. 1 minute. Should be minimized.
Kale, you are seeing share screen,
the Zoom poiduchu ipo. I have to come.
No, but we are seeing you.
You are seeing,
Oh, you are there. Only the share screen you will have to press. You will be seeing it. You are in Zoom only.
Okay. In the screen terida? Terila.
We are seeing you. No. Sahiti, guide her, no?
Ma'am, at first, please open the PPT, ma'am.
Yeah. I opened the PPT.
Okay, ma'am. And then come to Zoom.
Come to Zoom.
And then click on share screen.
I have to open and keep it. I have to minimize the PowerPoint. No.
Yes, ma'am. Yes,
You have
ma'am.
to minimize the PowerPoint.
Yeah,
And
okay.
then come to
And
Zoom.
come to Zoom. Click on share screen and then share.
Zoom.
Please click on
Go
share
down,
screen.
you will see the share screen.
Yeah, I got it.
Click on it. Click on it. Now you open your PowerPoint. What you have minimized and kept, you will have to open.
This one.
Where is your minimized PowerPoint?
Minimize PowerPoint on the desktop.
Seeing your entire screen.
Okay.
But it is on the right side of the screen, ma'am. Sepsis Unveiled. There's one PowerPoint icon.
But that has to be down somewhere, minimized one.
But madam was probably not minimized.
It has to be open.
Please click on the
you're seeing
PowerPoint
that
icon, ma'am. PowerPoint icon. Yes.
PowerPoint icon down.
Now make it in full screen.
Now make it
slideshow and then full screen.
Slideshow from beginning.
And then from beginning.
Okay.
Done.
Okay. So we do have panelists, Dr. Mangalagita, Dr. Preeti, Dr. Vidyashri, and Vijayalakshmi Sheshatri, who are gynecologists. And for dealing our complications, we have Dr. Angel and Dr. Prabhu and Vijayalakshmi. As we all know, maternal sepsis accounts for nearly 11% of maternal deaths worldwide and is the third most common direct cause of maternal death. And sepsis also contributes to other causes of maternal deaths like hemorrhage and thromboembolism. The new WHO definition of maternal sepsis is a life-threatening condition defined as organ dysfunction resulting from infection during pregnancy, childbirth, post-abortion, or postpartum period. So why pregnant women are more vulnerable to sepsis and its sequelae are the normal physiological changes that occur in pregnancy like hyperdynamic circulation, tachycardia, diminished oxygen reserve, hypercoagulability, and decreased immune levels. All these things exacerbate the physiological changes brought on during sepsis to make sepsis a life-threatening one in pregnancy. And we always find that postpartum period has a heightened risk of sepsis. That is mainly because the placental site, which is a large, moist, perfect condition for bacteria to thrive, and placental site has also a rich blood supply, directly leads to venous circulation. So septicemia occurs more quickly in the postpartum period, and all the tears and the cervix, vagina, and perineum traumatize the tissues, and these traumatized tissues serve as a source of infection, and hence women are more prone for sepsis during the postpartum period. And definitely we do have challenges in diagnosing sepsis. Many a time we say, if you don't have a proper diagnosis, we say that patient had died due to sepsis. So what are the challenges which we really face are due to the physiological adaptations and the hyperdynamic circulations, and tachypnea of sepsis is really confused many a times with that of physiological tachypnea. With this basic introduction, we move on to the case scenario. We have 4 to 5 scenarios. The first case, 24-year-old Mrs. Y, gravida 2, para 1, live 1, with history of 33 weeks of gestation, was admitted with draining PV per vagina. Patient was admitted and was given antenatal steroids, and she has had 5 vaginal examinations, and she also had antibiotic coverage. Now, the patient has fever with chills. So what is your clinical diagnosis? And do you have any clinical criteria to diagnose chorioamnionitis? Preeti, could you answer?
Yes, ma'am. Good evening, one and all. So the given clinical scenario is of a 24-year-old second gravida who has come to us in the setting of premature preterm labor rupture of membranes. So given the hint of multiple pervaginal examinations, I would just go in with sepsis state, more probably chorioamnionitis, ma'am. And clinical criteria, yes, there is clinical criteria for chorioamnionitis. Patient should present with fever, and the fever should be like measuring 100.4 degrees Fahrenheat lasting for more than a hour or more than 101 degrees Fahrenheat. Actually, low-grade fever on the first day of fever is excluded in the definition of puerperal sepsis. And apart from the fever, there should be maternal tachycardia more than 100 beats per minute. The fetus can present with tachycardia more than 160 beats per minute. And there can be uterine tenderness. The fundal uterine tenderness can be there.
The only limiting factor with respect to this clinical sign, that is the tenderness elicited over the uterine fundus, is if the patient has been under epidural analgesia, there's a term called epidural fever. Epidural analgesia per se and the medications given during epidural analgesia can mask such tenderness. So either there has to be a clinical diagnosis, we have to go with our suspicion also, and subclinical diagnosis also should be taken into account. Apart from this clinical criteria of fever, maternal tachycardia, fever, fetal tachycardia, and the uterine tenderness, and foul smelling amniotic fluid is another clinical sign.
So the most important clinical is fever. So whenever you have fever with this kind of history, as you rightly pointed out, you can diagnose chorioamnionitis. Now, what are the common risk factors for chorioamnionitis? You must know which kind of persons go in for this, or what are the common clinical factors, and do you take any kind of precautions in your setup to prevent? Because this is a case of leaking membrane, membranes. So she will be prone for chorioamnionitis. So what precautions generally you take in your clinical setup to prevent sepsis?
Good evening, one and all. The maternal sepsis is, you would see there are many risk factors for maternal sepsis. Mostly if the patient is obese and if the patient is a diabetic, if she's anemic, and in this case, if the patient had a PPROM and multiple vaginal examinations, or patient already is an immunosuppressed patient, or patient is on immunosuppressive drugs, all these will add on to risk factors for the chorioamnionitis. And precautions in the sense, these high-risk patients, always we have to be on the watch out for chorioamnionitis. And in patients coming with PROM, we can decrease the PV number of PVs done. You can just put in a speculum examination just to confirm whether the patient is having a PROM. And if the PROM is there, we can start her on oral antibiotics. And that's it.
Yeah. So the precautions, usually what we write in a case sheet is no more PVs, or we restrict the PVs for these conditions. As you said, diabetic patients are more prone. And PPROM, they said rupture of membranes during term, the incidence of chorioamnionitis is around 1 to 4%. Whereas if it is a preterm, premature rupture of membranes, the incidence of chorioamnionitis is roughly around 15 to 20%. So you must be more careful in women with PPROM. And what precautions Vidya has answered. And there is, people say that if you give steroids, your infection rate has been increased, it is increasing. So naturally for preterm deliveries, we usually give antenatal steroids. Is there a contraindication, or does it increase the incidence of infection?
Basically, when you look into
we cannot hear you.
Oh, just one.
Your volume is low, ma'am.
Am I audible now?
Now you're okay.
Yeah. So antenatal steroids leading on to sepsis in a pregnant woman is very unlikely, because majority of them you give the steroids and then have a delivery pretty early.
You'll have to be close, closer to the mic, Viji.
Oh, I'm very sorry. I think maybe
volume is low.
Down. Well, just 1 minute. Let me see if that's good. Okay. Am I audible now?
Yes.
Okay. See, antenatal steroids and the rate of infection, it seems to be much more for the neonates. We had a huge cohort in the Taiwan. There was a huge trial which was published early this year, where they looked into almost the whole population for 10 years. It's only possible in a country like Taiwan. And they realized when you give antenatal steroids, the chance of child developing an infection in the first 6 months after delivery was high. It was statistically significant. To look for trials about mother developing infection, we have not had much. So when there is a scenario where you require it, we are anticipating a delivery and you want it for the lung maturity for the child, give it. Otherwise, routinely giving it for a diabetic patient because you worry about delivery, there is no role. Unless you're very clear about delivery, and it's then otherwise no point in giving antenatal steroids. And with regards to the precaution, I want to add something. There are times when you have to do PV and all. Two things always remember, it has to have a perfect sterility. You have to open a bin, you have to kind of drape it around the lady, make sure you paint it properly, wear a sterile glove. And even when you're putting the it's probably a sterile ointment which you have to put in your hand before doing the PV. This sterility is very, very important to prevent sepsis. Second, decrease the use of catheters. A lot of times when I find chorioamnitis, you would see them having some risk for premature delivery, and almost all of them are on catheters. If you can get away without a catheter, that also will help.
So as you said, using an ointment while during PV, restricting to diagnose using a speculum whether she is leaking may prevent to a certain extent sepsis. So what is the role of antibiotics, and what are the antibiotics of your choice?
Yeah. Antibiotics, I think, do have a role here, definitely. And we do give an empirical choice of antibiotics. Before, of course, the moment patient pertaining to this particular case, I think we would take a high vaginal swab. We will go through blood counts. That's the routine we always do. And but we don't wait for the reports to come, because that will take a little longer. And meanwhile, because the amniotic cavity is already open, we need to cover it up with antibiotics along with all other precautions that we have already discussed. And generally, we can take, of course, antibiotics. We can either use third generation cephalosporins, or we can use simply the... Preeti, can you mute? Or we can simply give ampicillins, amoxicillin. We do give these as a routine. And of course, nowadays they say even you can give azithromycin 2 grams single dose. All parenteral till we get back with the reports of the high vaginal swab, or we have any other evidence of infection where we need to pick the antibiotic of correct choice. Of course, clindamycin comes very handy as well, and amoxicillin, ampicillin, penicillin, cephalosporins, and now with azithromycin as well. I think Vijay Balakrishnan can support this or can add inputs to this. Of course, if it goes into a little severe, we can always have meropenem, imipenem, all those things. But right now, I think with this condition, I would prefer only these initial antibiotics till we get the reports.
Thanks, Dr. Sheshadri. I thought they'd reversed our names. When I saw the questions, I assumed they probably reversed our names. It was similar sounding.
Even I thought so. That is why I thought... That is why I thought whatever we do, I will write and then get your expert opinion as well.
I would divide into two categories. Somebody with a definitive diagnosis of an infection, or when you are worried about an infection. Like when somebody presents with some kind of show, but at that point of time, you don't have fever, you're not really sure, you have high risk. At that time, try to avoid antibiotics, try to avoid manipulation, keep a clean watch. If somebody has manifestation of infection with fever, vaginal discharge, something to either a PPROM, at that time, choose an antibiotic. What antibiotic we have to give depends upon what we are expecting there. What do we expect? Coliforms. Very rarely, you may have gram-positives in India. Majority, it is coliforms. Coliforms with covering group B streptococci. So usually when a patient comes in sick, your drug of choice will be something like piperacillin tazobactam, 4.5 grams, Q6-Tarly, or cefiperazone sulbactam. If the patient is okay when you're not really sure, you can go with ceftriaxone. If there is no fever or clinical signs of a chorioamnitis, wait. When we give an empirical antibiotic without an infection, there is always a chance that they will develop an infection which is resistant to what we are giving. So try to keep it as narrow as possible once the sensitivity comes. Let's say the patient comes in with vaginal discharge, high-grade fever. Patient is sick, we start on piperacillin tazobactam after sending high vaginal swab and blood cultures. The high vaginal swab comes as a sensitive E. coli. We should go down to ceftriaxone. We should not assume just because the patient recovered, we will continue with piperacillin tazobactam, because the narrower the spectrum, better the long-term outcome.
Yeah, but Vijay, what happens is when the patient comes presenting with PPROM, we do have, she's not into labor. She's going to go into labor after some time, depending on the gestation or the way we manage. So do you mean to say that if she doesn't have an additional fever or other symptoms where we are expecting a real problem, we don't cover with antibiotics? We are talking
about PPROM. Patient coming with PPROM without signs of sepsis, we are evaluating. Go for something like azithromycin. Give 500 mg at labor, then it's a higher dose. 500 mg, send off cultures, wait. If she shows signs of sepsis, a clear-cut sepsis, go for something like beta-lactam lactamase inhibitors. It is borderline, put her on something oral, wait and watch. If there is nothing, somebody comes with high risk with the possibility of show, but nothing is there, please don't.
But patient presenting in a preterm labor is per se subclinical chorioamnionitis, no ma'am? Like presentation with a preterm labor per se.
Because the vagina already, because there is some kind of infection only, she's going for
colonization only. Preterm labor.
So what we assume and do is we give them one shot of antibiotics whenever a person comes with PPRM. And as you said, we can send them on a high vaginal swab and we'll get a culture report pertaining to that particular organism. We can change our antibiotics. But in our setup, we usually give an antibiotic.
We always give.
Okay. So now what are the maternal and fetal effects? Why are you more worried about chorioamnionitis? What kind of effect it can have on the mother as well as on the fetus?
Mangala.
Good evening, ma'am. Good evening, ma'am.
Yes.
Am I
We can
audible,
hear
ma'am?
you. Yeah, you're audible.
Yes, ma'am. Usually these PPROM or otherwise chorioamnionitis have more morbidity on both the mother and the baby. To the mother, they actually cause say minor, initially they will have fever and symptoms of fever, but can spread over and cause peritonitis, can even further go on to renal failure, and then septicemia and septic shock is a problem. Regarding obstetric complication, she can have adherent placenta because of infection. Chorioamnionitis, the placenta may not separate out well. She can have post-delivery, postpartum hemorrhage. To the baby, it can cause sepsis in the baby, neonatal sepsis, and all forms of neonatal complications due to sepsis can arise. And mostly in the mother, we are worried about septic shock and post-delivery PPH.
Yeah. So whatever sepsis happens to the mother goes to the baby also.
Sometimes if we have missed that or patient comes late, it could present even as IUD.
Yeah. So sepsis is thought to be a consequence of body's inflammatory response to the bacterial endotoxins and exotoxins, and cytokines and immunomodulators are produced by the body to fight these infections. And in large quantities, their release causes succession of critical events involving multi-organ systems. So when infection is untreated, this response can cause organ dysfunction, septic shock, and death. See, there is a sequence of events that take place. Usually the infection is an ascending infection, mainly due to PPROM. It is not only that, even an hematogenous infection can also lead on to chorioamnionitis. So we should not say that only because of draining PV ascending infection had happened. Even a hematogenous spread, even in a term infant, can also lead to chorioamnionitis. So they say these are the steps that happen where the patient may go in for septic shock. Initially, we have an inflammatory response and we have the clinical signs as Dr. Preeti has said, temperature more than 100 degrees or less than 96, respiratory rate more than 20, heart rate more than 90, and your WBC count more than 12,000 and CO2 less than 32. This, when you have two symptoms of systemic inflammatory response, you know that it is a definite case of sepsis. When you go in for an end organ damage, then you call it as severe sepsis, and there the lactate level may be more and your systolic BP may come down and you will have hypoperfusion. So in that case, when you give fluid therapy and hydration, if it is getting corrected, you can curtail the infection. But even after fluid therapy, you're not able to correct the sepsis and you need vasopressors in addition to that to control your infection, then we say that the patient has gone in for a kind of septic shock. So now the patient is slowly drifting from sepsis to severe sepsis and is now ending up in septic shock. How you want to curtail this, or can you cut down at that level? You can prevent a patient from going from severe sepsis to septic shock. And how is an intensivist, Dr. Prabhu, you can manage septic shock?
Yeah. So The thing is, how do you curtail this? It's very, very difficult to do anything because it's the body's response to an infection or an inflammation. So curtailing this is very, very difficult. But only thing is, you don't allow the patient to go into severe sepsis. That is the only way to do it.
Go into that.
Infection, instead of going into a severe infection, if you can curtail that infection early stage itself, then you can probably avoid going to this septic and septic shock. So basically, if the patient is septic shock, what exactly you do immediately? Mainly taking care of the airway, oxygenation, and intubation as and when needed when the patient is in distress or when the patient is more hypoxic. So taking care of the airway, unobstructed airway, and then simultaneously, it's like, lot of things are going to be done at the same time. So simultaneously start IV fluids and noradrenaline as an initial vasopressor. Because if you delay the IV fluid, if you delay the vasopressor, and if the blood pressure is going down, then we have a crashing patient, right? So you have to start vasopressor. 2 large bore intravenous peripheral cannula will be more than sufficient to start with. And once you give a lot of IV fluid boluses, somebody can load the noradrenaline and start. Don't give dopamine because nobody gives because of the variable effects. So immediately start resuscitating the patient with large amounts of fluids, approximately around minimally to start with around 30 ml per kg body weight. So all of us will be weighing around 50 to 70 kg. Approximately, if you can give 2 liters to start with, that will be more than sufficient. Now, what will be your endpoint? So as long as the blood pressure is 90/60, it's more than sufficient, or a mean arterial pressure of 65, it's sufficient, because we are all dealing with young pregnant women. So you need not go for a 120/70 blood pressure. One. Second is, during blood gases, I'm seeing whether there is any acidosis is there or not. If there is acidosis, improvement of the acidosis by doing serial blood gases is one of the indicators. Third is urine output. So monitoring the urine output, starting the IV fluid resuscitation, already somebody will be catheterized, so it should not be a major problem. So as long as the urine output is more than 0.5 ml per kg per hour, at least around 30 to 35 ml per hour to start with. And once you give fluid resuscitation and take care of the airway, then it becomes easier to handle. Then third thing will be what else you can do. If the noradrenaline is not going to, not increasing the blood pressure, then you add vasopressin and then add adrenaline. These are the 3 vasopressors we usually start. In the meantime, somebody can play central line and all that. Most importantly, what I feel is, what is the endpoint? What is the goal you are dealing with? Simultaneous resuscitation, goal of the blood pressure, bicarbonate, and the urine output. If you have a lactate, you can have a measurement of lactate. That will be more than sufficient. So this is one part of the resuscitation. And then simultaneously taking the blood cultures, because we are dealing with critically ill patient. So before you administer antibiotic, it will be better to take a blood culture to start with. So this is to give a bird's eye view, even though a lot of things are involved. If somebody is very scared about giving fluids, what I would say is, while giving fluid resuscitation, if the patient is tachypneic or hypoxic, then you can probably get worried. Otherwise, young patients, they can tolerate even 5 liters. Should not be a major problem.
Okay, so is it also, a continuous monitoring of the vitals?
Yeah,
of course, that's a part of your management, but just
what I am trying to tell you is, as an obstetrician, till somebody can come and shift the patient, you can manage all these things. It will be wonderful. So, of course, the patient should be monitored in the ICU. So that is what I would say.
So many a times we have patients in septic shock directly coming. So we don't know what really happened before, whether they have control, given antibiotics and all that. And as you said, we can give 3 vasopressors. So give IV fluids first. And if it is not getting corrected, mostly you should have to go for vasopressors.
Only one point, madam. If the blood pressure is borderline, you have time to resuscitate. If the blood pressure is 70/50, next is going to be crashing patient. So start noradrenaline by putting one more peripheral line. Simultaneously resuscitate the patient. Once the blood pressure picks up, when the pulse comes in, the first thing is to place an arterial line, and then you place a central line. I would say, if you have a good 2 peripheral lines, that will be more than sufficient to start with. You have time. Then you put arterial line, you will have an idea of what is the true blood pressure.
because majority of the time your NIBP monitor, it underestimates the lower blood pressure and overestimates the higher blood pressure. So you will have some control over the blood pressure, which will be going to be the target. 65 MAP or even 90 by 60 blood pressure is more than sufficient.
I think putting an arterial line, the gynecologist cannot do either.
Need a multidisciplinary team.
Yeah, but that is the reason why I didn't go into the lines. So I
Yeah.
thought resuscitating the patient and what is your goal? If your goal is achieved, then you have people to come and take over.
Okay. Thank you, sir. So RCUG now recommends the use of MEOS to detect signs of sepsis to trigger escalation and for senior review. And they have found out it has 89% sensitivity in identifying maternal morbidity. So we do have what we call as red flag signs, which we always insist our postgraduates to mark it so that we will know where we are. So the main important parameters which has to be looked into are respiratory rate, oxygen saturation, temperature, systolic BP, diastolic BP, heart rate, and her neurological response. And these are the red alert signals. When the respiratory rate is less than 10 or more than 30, when your oxygen saturation is less than 95, your temperature again less than 35 or more than 38, systolic BP is more than 180 or less than 90, and your heart rate more than 120 or less than 40. We usually, what we do is we print out this paper and keep it in the sheet so that this, even in Lakshya, what they have pointed out is these signs have to be monitored periodically. And once when the patient is going in for red alert signs, when they have that, you have to inform and get opinion from us. But this will move on to the anything you want to add?
Yeah, no,
yes.
I just want to ask Prabhu, are we, why they say that this Q SOFA and all, do you follow or not? Not necessary?
Yeah, correct. The point is the Q SOFA
pregnancy, they say it has no meaning. So I was just...
Yeah, but see, one thing I'll tell you is these are all red flag signs. You can pick up things in the ward.
Yeah.
That is the
That's the target
of it.
Only thing is the cutoff is a little bit different when compared to a non-obstetric patient. Obstetric patient 130 per minute beats and 90 by 60 blood pressure. So that minor difference is there. Otherwise, actually nobody monitors Q SOFA. I don't think.
That's why I was asking.
People are monitoring.
Yeah, correct. That indicates failure. That's what they say.
See, but serum lactate is the most important indicator to diagnose sepsis. Is it so, sir?
Correct, madam. But it's going to be expensive investigation. That is why I didn't tell. ABG will be the basic thing to do and checking the vital signs. These are all the and urine output. Majority of the time, you forget the acidosis and urine output. So these are the two parameters that you can pick up early. Something wrong is happening. Unexplained tachycardia of touching 130 plus 130. Something is happening. That's all.
Okay. Thank you, sir. We now move on to the second case. 25-year-old Mrs. X delivered 3 days back. Now complains of severe lower abdominal pain, fever on and off, and an abnormal vaginal discharge. On examination, she was found to have tenderness in the lower abdomen with foul-smelling lochia. So what is your diagnosis? This
patient is presenting on the 3rd day of her delivery with fever and lower abdominal pain. So now we're thinking of a pupil sepsis and on and off fever. The one thing that should not that should not be definitely missed in a postnatal or a post-operative ward is the vitals of the patient. We should never miss a fever. We should never miss any focus of infection, particularly things like mastitis, complaints about UTI, URI, anything for that matter. Whatever comes out of the patient's mouth should be given respect and due concern should be paid over it. So with the diagnosis of pupil sepsis, the risk factors being, as already discussed for chorioamnionitis, a patient who is anemic, malnourished, or high-risk conditions like diabetes or immunosuppressed conditions, or in a family if she has contact with, because this group A beta hemolytic streptococcus is most commonly implicated in the causative of a pupil sepsis. The textbook says, if there's a contact with a group A streptococcus infection. But then in our scenario, we see more of coliforms and Klebsiella, whatever HVS and urine cultures that we send. So we should be careful when we meet such patients, and we should never miss the focus of infections. The causes being, even the common salts become the causes. The ureaplasma area become the mycoplasma. But then gas is the most common cause. We see staphylococcus also. That's why we are thinking of toxic shock syndrome always in the mind, one of the dreaded complications of puerperal sepsis.
The diagnosis is more important here. Routine monitoring of vitals, monitoring the temperature, uterine tenderness, fever, all these things becomes more important. So, Shaya, who are at risk developing? I think Preeti has answered. Vidya, you want to explain a little bit?
Yes, ma'am. As she answered already, the puerperal sepsis, one, it can affect the uterine infections, ma'am, or it can present as pelvic infections. Some patients, they also present with breast infections and all the systems like can present as urinary tract infection. And any wound infection, if it is a LSES, it can present with a LSES infection or a episiotomy wound infection. And pelvic thrombophlebitis, all this can be the presentation. And as she said, any complaint from the patient should not be, it should be looked for, and the signs should be looked
routine
for.
signs should be asked for. Routine complaints, even if they don't come out with that. Sometimes routinely you should ask the patients. And examination.
And other predisposing conditions, other than that, if already the patient is anemic or a diabetic and history of bacterial vaginosis, if the patient has had a prolonged labor lasting for more than 12 hours, or the patient had any instrumental delivery like forceps or vacuum, and if the patient gives history of PROM and repeated vaginal pinch, all the more she is prone for all these puerperal sepsis.
Yeah, any handling of the uterus, removal of the retained products, all these things. The more you handle with the patient, the more they have infection.
And endometritis and endomyometritis can be the initial presentation mostly.
So again, what will be your choice of antibiotics? I think Vijay Lakshmi Madam had answered. I've given it to Dr. Prabhu. And second, what if you do, suppose these patients, even if you give some kind of antibiotics, they never improve. They will have to, they continuously used to have high fever. In that case, what will you do, and what are the anticipated complications these patients can have, and how will you manage?
So there are three parts to it. First is choice of antibiotic. See, the choice of antibiotic, okay, by guideline, Stanford guideline very clearly states that you have to cover Streptococcus, Staphylococcus, and anaerobes. So these are the common organisms, and of course, E. coli and all that. So either piperacillin tazobactam, like a beta-lactam is inhibitor, or a carbapenem. If the patient is so sick like this, you can even go for a carbapenem, like imipenem, cilastatin combination, or a meropenem. But the problem is, you need to have an local antibiogram by liaising with your microbiology department. Generally, what is your flora? Because it all depends on what are the common organisms you get in your hospital. So, given that this patient is not gone anywhere directly coming here, most likely either a piperacillin tazobactam or an imipenem that is more than sufficient to cover the anaerobes and your Streptococcus and Staphylococcus. These are the common choice of antibiotics. It all depends on how sick is the patient. If the patient is sicker, you can go for a carbapenem. Tazobactam will be sufficient. Second is, what will you do if there is no improvement with antibiotics? So, as everybody knows, 24 to 48 hours, you have to have some sort of a stability. If there is no stability, that means there are only a few possibilities. One is wrong infection, wrong organism, wrong diagnosis, and wrong antibiotics. These are all the common things. Once you have ruled out your problems, then you go to patient problem. Wrong choice of antibiotic. If you do something starting only amoxicillin clavulanic acid for such a patient, then it may not be of much value. Then wrong infection. Yeah, you are missing something and something else is happening. You're treating the other infection. Then wrong diagnosis. Then the total diagnosis can be wrong, and somewhere else
it happens.
So these are all the common
might be retained products or something like that, where the source of infection had not been removed, and the patient would have continuous fever and all that. So we have to recheck your diagnosis.
And do an imaging, ultrasound at the bedside to know. Nowadays, obstetricians do left and right ultrasound to see whether there is any retail products of conception and all that. And if there is nothing there, then an CT imaging will be sufficient to rule out any peritonitis or intra-abdominal lapses. So these are all the common problems which you face. Even a septic thrombophlebitis, it can invade the veins. So these are all the common problems of non-improving patient. So in that case, depending upon your CT findings, either the patient should be taken up for a laparotomy or whatever. That obstetricians and the surgical people can decide what is to be done.
So I had put this question because many a times what happened, we think it is a simple puerperal sepsis, but the patient would have had a forceps delivery where a mite extension would have been done into the broad ligament, it would have formed an abscess, and later 3 or 4 more days, the patient come and present as peritonitis. So as you said, a radiological investigation, go back and analyzing your diagnosis will help you in clearing this.
And what do you call as a golden hour? Like how much? Of course, it will vary from individual to individual, but generally how much?
Wow. All of the septic shock guidelines, it is going to be very difficult because practically, because they say within 1 hour, if you have to give antibiotic, take blood cultures, start in central lines, and all these things should be done in 1 hour. But the source control, that identification, you have 3 hours time, and then do the control of source, like not a definitive procedure. At least put a drain and come out, do a laparoscopy. Those things that should be done within 12 hours time. So this is the septic shock guideline, which clearly states that once you identify the source control should be done within 12 hours.
12 hours.
Thank you.
Thank you, sir. We'll move on to the next case. Mrs. S, 33 years, para 1 live 1 with a body mass index of 36, known diabetic on regular treatment, was delivered by emergency LSCs in view of fetal macrosomia. She has a serous discharge from the skin wound on post-operative day 3. So what is your diagnosis?
Yeah, you have yourself put, and it definitely looks like a surgical
I have
site
put it on another slide. That covers this. Okay, ma'am.
No, surgical site
visual diagnosis.
Yeah, we will take it as surgical site infection. The reason being is it is at the surgical wound. We do have classification either of a superficial SSI or when it is just at the skin. A little deeper below that in the muscles and the other tissues, we can call it as a deep SSI. And of course, there is one more thing called as space or organ SSI, where it affects the organs. See now, this particular SSI, I would think, looks like either little superficial or deep in your picture. But we also have a kind of in our hospital, whenever we do, and here, we know there are 3-4 major issues which have caused this perhaps. One is it's an emergency cesarean which has been done. There is an obese patient. It's a diabetic case. So probably the SSI is expected in case we have not done. Many times it is not the skill alone. But we in our hospital, whenever we are doing a surgery, we are asked in the beginning itself whether the risk factor for SSI exists, by way of saying that it's a contaminated wound or dirty wound, or a non-contaminated clean wound, or a clean contaminated wound. So whenever you are going to touch an organ, the possibility of contamination is always there. So we do this, during the timeout for any surgery in the beginning itself. So our anticipation goes into whether we can follow this up closely for SSI.
So because this is a known diabetic case, that is one risk factor. Obesity is another risk factor. So in these cases, what kind of precaution do you routinely take, or on the day 3 you have found out some kind of discharge? Do you do anything on that particular day? Mangala Gita?
Yes, madam. Precaution is maintaining sterility. We can ask the patient to have a good bath, even if it is an emergency cesarean, or at least a good abdominal wipe with soap and good cleaning the area is very important. And then giving an antibiotic with either just prior to starting the anesthesia or even 15 to 20 minutes earlier, we can give a test dose and an antibiotic cover. And regarding the procedural, we should not avoid to make it delayed procedure. It could sometimes very prolonged procedures also can lead to sepsis formation and wound suturing. the techniques are also there where they have to follow good techniques of skin-to-skin approximations. Should be a wound dressing after 24 to 48 hours, and then give it open. Open dressing is always preferred for better healing purposes.
I think we can ask Angel and Madam. Madam, if there is going to be a pendulous abdomen, at what point you'll put the incision and any method by which you suture or any particular dressing material you use to prevent infection? Angel, ma'am, are you there?
Yes, madam.
Yes, ma'am.
Am I audible?
Yes, ma'am, you're audible.
Okay.
How we are going to deal with these individuals?
Actually, almost all points have been brought out. The first thing is, when it is becoming an emergency procedure, there is a risk. The risk goes up. Inadequate preparation of the skin, pre-existing skin infections. Certain times there is a in the fold that already has a fungal or pre-existing skin lesion. Of course, you were told about the comorbidity of obesity and diabetes. And coming to hospital side problem, their preparation or the staff who deals, there is no barrier nursing. There is transfer of organisms from one person to the other when they use the same glove or they examine the one person and the next person without hand sanitation. And of course, when you are giving an antibiotic, we always should have an antibiotic protocol of the ward. And nosocomial infection can be a real risk factor. And coming to the prevention, preparation time, if it is possible, give the contact time of antiseptic scrub, minimum of about 6 minutes at least when you are using betadine scrub, so that before you make the incision, give a good adequate preparation time to the skin. And sterility of the procedure, using instruments and mops and sutures which are completely sterile. And coming to the surgical technique, when you are making an incision, we rather want you to avoid a very low incision. Rather, we prefer a little higher incision, which is not very close to the perineum. That is, this way, the abdominal flap which you raise above is not having much of traction. You don't exert, that is, you don't pull the upper portion of the flap. There is not much of diathermy, and you can avoid hematomas. And in case there is a little bleed or anything, don't hesitate to put a drain, because any collection inside is more dangerous than actually keeping a drain. Now we have safe negative suction drains. These can avoid occurrence of infection. And when we apply the dressing, first day anyhow after the surgery, we always put an antiseptic ointment on the suture line, and of course a sterile pad and bandage. And when cases of these pre-existing problems are there, safer is to do the wound inspection within 72 hours. And if there is any suggestion of fever or pain or redness, better is to open up, see if there is any collection. And in case there is a collection, remove few sutures, take a swab and send it for culture and sensitivity. And we advise negative pressure wound therapy. That is, we put a foam with a suction and connect it so that whatever exudate is there comes out, and there is a better chance of wound healing.
So when there is a serious discharge, it is better to let out the fluid on the third day, removing 1 or 2 sutures if it is going to be an interrupted. Do you prefer a continuous, sometimes we usually do a subcuticular. Is it better in these kind of individuals or it is contraindicated?
Madam, I rather prefer an interrupted suture, which is safer, because you can definitely be sure that there is no collection underneath and there is no total dehiscence. Because when you make a beautiful subcuticular suture, the collection remains inside. And there is a greater chance of infection. The collection becomes infected and dehiscence, and ascending infection in the abdominal wall is more in those cases.
Hi, doctor. How about the staples that we give, intermittent staple?
It's if you are having a staple, very good, madam. It's as good as it's quick because rather than doing a suturing, it is very pretty to apply, very fast to do it also, madam.
Yeah, thank you.
So staples are better.
Ma'am, and for
Only thing
every
is the
dressing,
cost.
Yeah, but we are doing it. So
yeah, that's it. Cost, if they can afford, definitely, it's definitely better.
Yes.
ma'am, and for every dressing, RCOG recommends adequate analgesia and anesthesia, ma'am. Like, what kind of anesthesia practices can we use in our ward OP setup? Like, what do we actually generally use? We just give oral medications, but then RCOG specifically says the patient should have adequate analgesia or plan an anesthesia before each dressing.
Dressing.
Yes, ma'am. Each wound dressing, the protocol says. So
Madam,
that
actually,
maybe the slumpectomy will be perfect and the wound gets healed well.
Madam, actually, if you're going to do any intervention, for example, it is going to be a discontinuity of the skin, that is, there is a necrotizing fasciitis or infection. If you have to cut the tissue, you can infiltrate local anesthesia, which is going to be definitely helpful. We actually put up Sofrotool or lubricated antiseptic gauze over the suture line, and then a gauze and pad dressing. So when you remove such a dressing, there is not much of pain because it is the suture site. Of course, when you are trying to release the edge of the plaster, that is the only, because there may be few areas which is over the hair follicles, which is, so give a proper traction, counter traction at the edge. You can even moisten the edge of the plaster with either spirit or normal saline so that it just lifts up. That thing should be good enough. Only in pediatric age group, we prefer a sedative, this thing. Usually in adult, as you said, oral anesthesia, we gain their confidence, make them relax, make them in a comfortable lying position. We are also in a comfortable posture so that we don't actually unnecessarily produce a traction over it. And in case you need, it is a very, very sensitive patient and you need to give anesthesia, you definitely you can give things like a short-acting injection like ketamine or something. But most of the time, we have never done it. It is only for procedures which require cutting.
Regarding placing the incision, madam, many a times we have a pendulous abdomen. They go and place that incision in the cleft. So they do a cesarean. Then after some time, you will see the whole incision is being closed by the pendulous abdomen and it will never heal. Is that right, or it is better to place it a little bit above?
We prefer the line that is between anterior superior iliac spine of both sides, madam. That is the ideal site. So when the patient is kept in the lying position, mark the anterior superior iliac spine on both sides and draw an imaginary line. And at that point, if you give an incision with a little upward curve, that is the best incision, which almost comes within the bikini line, and that avoids much, that is excessive traction which you would give when you are trying to raise the flap in the superior aspect. That gives a better outcome also, both during surgery and in the long run.
Like there is a question in the chat box.
Yes.
Patient sutures placed in the fat layer for opposition, will that increase the chance of infection? Ma'am.
Fat layer, madam, you need to close, but it should not be under tension. So we rather prefer to use an absorbable suture, either a catgut or a vicryl, but it should be having enough space and it should not be under tension. If there is an excessive fat, we as plastic surgeons prefer a drain in that area. As I told you, a negative suction drain. so that definitely there is a fat necrosis that goes on, madam, because of the tissue tightening that happens. So in that case, a drain will be safer.
I think everyone would have had this kind of situation, I think. Now this patient on the 8th day, the picture is like this. So what will you do, ma'am?
Again, ascending infection, madam, necrotizing fasciitis. Certain times the outward skin may look okay, but there is a little erythema, tenderness, induration, and if you there may be the foul smelling discharge just coming out, and when you remove 1 or 2 stitch, you can see the underlying yellowish sloughed tissue. The commonest are the skin commensals, the streptococcus and the staphylococcus. Management, here we will have to debride it. Without debridement, it is not going to heal. So this is usually taken up in an OT with adequate anesthesia, without which we will not do justice in removing the necrosed areas, because the necrosis will be extending far above than we really see outside. So we will have to keep slicing the dead or the necrosed slough tissues till we get a clear, good capillary bleed that comes from the skin. And in the deeper layers, the fat should appear healthy. The color and the texture of the fat when you are cutting should definitely show that it is healthy. In that level, we always close with a drain. And we don't mind actually when we are doing these things, we are not bothered about getting a very good aesthetic closure. We rather want that to be eliminating the septic foci that is there. So we thoroughly debride, and especially in the puberal, their skin is lax. So we will be able to get a very good closure.
Keloid, Dr. Angeline, do you think keloid formation is specific to people or specific to the surgical technique or closure technique?
Madam, it is actually specific to people. Yeah. And surgical techniques are not actually, if it is closed under tension, there is a chance that there can be an increase in the scar formation. But that question doesn't arise when you are doing a LSCS, because definitely when we are doing an abdominoplasty, probably yes, we may resect much of tissue, we may be closing it under tension.
No, we get patients, madam, who are previous cesareans. They have a keloidal scar. They do get it.
That is the keloid scar. If it is the persisting infection is there underlying, madam. That is the cause for keloid is, one is genetic. Second is tension over the suture line. Third is if there is a, if there are follicles that are entrapped, the hair follicles or the sebaceous follicles that are there, which are entrapped into the scar, which lead to a recurrent infection, that can lead on to the keloidal scar. So if it is genetic, we may have to only avoid it by early application of massage. Then we have ointment, silicone gel sheets, compression using a panty line exactly over there, so that the that can be reduced. And after a few months, we can usually, after 8 weeks, if there is still an hypertrophy that goes on early stage, we can even start injecting triamcinolone acetate, that is injection Kenacort, into the scar to reduce it. But if it is coming under control with the silicone gel sheet and compression, we are rather advise them to continue till the scar matures, madam.
How long do you wait, madam? Sometimes they'll be going on doing the dressing till it becomes reddish and all that. And they spend nearly 10 days for that. Every day one house surgeon will be removing only that dead tissue. Do you advise immediately within 2 or 3 days, or is there any time limit?
Depending on the general condition, madam. Suppose the patient definitely has signs of fever, increasing induration, foul smelling discharge, it is better we intervene early. We are sure that there is a underlying infection or underlying dead tissue or necrosing fat that is continuing. So better is to take it off early and so that the post recovery is faster. Suppose we keep on continuing the dressing, unless the dead tissue is taken off, there is no point. There are debriding ointments like pepine urea ointment, Debride, Solutil, that can be applied. That can be for localized areas. Suppose some small area of slough is there, then probably apply that debriding ointment, put a saline gauze, check after 24 to 48 hours. If that is coming off and the wound is healthy, then probably continue dressing. And in these cases, what we talk about the negative pressure wound therapy, that is the VAC therapy, which is now available both commercial and in the hospital. Even in government hospitals, we have the central line suctions. We use a sterile sponge and offsite and just put a suction tube over the wound and connect it to the central suction. That gives a negative pressure to the wound, which allows a very good healing. So the commercial ones cost about 8,000 to 12,000 rupees, whereas the what we make for the patient in the government setup, hardly the sponge and the cling field and the suction tube works to around 300 to 500 rupees, which is easily possible to be done, which takes away the collection and gives a clean, that is proliferation of the capillaries take place and the wound healing is definitely accelerated.
So better to be suction given for 24 hours or is it given as intermittent suction?
Madam, suppose the pressure we maintain is around 100 to 110. We actually give it for 1 to 2 hours. When the patient complains, we discontinue it and keep it as a cycle. If it is kept at a lower pressure, 70 to 80 millimeters of mercury, then in that case, it can be kept as a continuous suction. That is usually available in the commercial versions. So all those modifications. In a setup where we just connect it to the central suction, we use it for 1 to 2 hours, then discontinue and redo it the evening or the next day.
Thank you, madam. Next, we move on to the next case. We are in want of time, I think. 24 years, Mrs. K, delivered by assisted vaginal delivery, now complains of pain in the episiotomy wound and gaping on the 5th postnatal day. What is the commonest cause for this? And anything regarding suture material which we have used? Preeti?
There's a case of episiotomy wound infection. It can be like either due to a wrong technique or suture material, but with respect to technique, it has neither to be too tight or too loose. Both are going to be useless for the patient. Sure, tension sutures are not required for episiotomy. So the right kind of material needs to be selected. So what the literature says, like braided sutures, straight and rapidly absorbable polyglycolic acid sutures are acceptable ones. But what are we actually using? We are using catgut. So catgut versus synthetic sutures, both are good. And the success rate is 95% for both. So we can't say this is good, that's good. But then Vicryl is used by a few, but Vicryl is not being suggested. But with comparison with respect to chromic and plain catgut, chromic catgut takes over. So that is the preferred material. But polyglycolic acid sutures are the
Vicryl rapid with antibiotic impregnated, where it has earlier absorption.
Yes, ma'am. Yes, ma'am. So rapidly absorbable are the ones which are being suggested. Yes.
So what are the postnatal complications you anticipate here and any kind of perineal care you routinely do in your hospital?
Yes, ma'am. Usually when the episiotomy wound gets infected, the patient is having pain even during walking. She's not able to sit down comfortably, even using the restroom. They will avoid going to the, restroom frequently and urination. And so there will be, unknowingly, she will be delaying the passing of urine. She can go in for urinary tract infections. They can also ascend via the episiotomy wound infection, so she can go in for UTI, and then septic thrombophlebitis can happen. And when very florid and severe wound infections can even cause fistula, so it can go posteriorly. The rectal vaginal fistulas can happen. It is usually common. Infection wound gaping can occur when unknowingly they leave behind a small hole in the anal area or in the rectum, and they close the episiotomy. When unknowingly, if episiotomy is wrongly closed, they can have RVF. And then many complications like pain, and when the thrombophlebitis spreads, then she can go in for severe other complications like renal shutdown and other septicemia.
Always look out for thrombophlebitis. So for CPT, it's a separate topic by itself. Where, Madam, can you speak few words on CPT management?
Yeah. CPT, number one, we have to identify. I think that is the best part of
identification.
Identification, and if especially junior obstetricians or postgraduates, I think very, very important to put in a finger in the rectum and rectal examination before even they suture. Otherwise, they will miss it, and then it becomes a
problem. Early identification.
Chronic tear, and that becomes difficult. So now it is very important, once we have identified, only the senior obstetrician who is understanding how to do it should be able to do. Done in the theater under good analgesia or anesthesia. And then very important that you identify what all has got traumatized, especially if you are talking of a complete perineal tear, the 4th degree tear. We know external sphincter, internal sphincter, the complete perineal body, and the rectoanal mucosa. And so properly we have to suture, and accordingly we all know we keep the sutures inside. And that is very important. And of course, the antibiotic cover we do. And in short, only this. Otherwise, we know we have to take care. Otherwise, we are going to have problems of
sepsis. Unidentified CPT may lead to sepsis. We move on to the 5th case. 22-year-old Mr. D had antepartum eclampsia. Cesarean section was done, connected to the ventilator. Patient now has fever with bilateral course crepitations on post-operative day 4 with diminished air entry on right side. So what are the probable causes, and what are the risk factors? Nearly most of the cases where we deal with death is due to ventilator-associated pneumonia. When to suspect it, how to monitor these patients, and any imaging techniques to be adopted. Professor?
Yeah. So what are the possible probable causes of the moment you say ventilator-associated pneumonia? It's a gram-negative bacilli or a Staph aureus. That is the commonest cause. So again, they'll say early VAP and late VAP. Early VAP will be less than 5 days old. That is, you have to understand, it's a ventilator-associated pneumonia. They should come after 48 hours of mechanical ventilation. If you have an infection already and the patient gets ventilated, then it is not ventilator-associated pneumonia. So it should be very clear, either tracheostomy or an intubation after 48 hours, provided the patient is not incubating the infection before the intubation. This is the criteria. So when you have a VAP, it's an early onset or a late onset. Early onset is like our patient who is less than 5 days old. What they say is E. coli, aerobic gram-negative bacilli, E. coli, Klebsiella, Pseudomonas, and then Staph aureus. These are all the common causes. Of course, Proteus. So if it is late onset, then the flora is different. Acinetobacter, multi-drug resistant Klebsiella. So these are all the risk factors for multi-drug resistant organisms. Why we need to know is early or late is the antibiotic choice may vary, which I think Dr. Vijayalakshmi will tell you. So these are the probable causes of ventilator-associated pneumonia. Now, why?
Yes, sir.
Yeah, madam, you were saying something?
No, imaging techniques. Anything that should be done. Every time we put a patient on a ventilator, she invariably goes to ventilator-assisted pneumonia. Most of the patients, somehow they go in for that.
When you suspect that we have ventilator-associated pneumonia, it should be both radiological, clinical, and investigational, all the three put together. That is why I thought I'll answer the third question of when to suspect. When to suspect is the most important. Fever or hypothermia, or leukocytosis or leukopenia, or the bandemia, 10% band forms, sputum, volume production, and purulent secretions, and hypoxia. So new increasing oxygen requirements, or the patient continuously having tachypnea with a high airway pressure. Sometimes the airway pressure alarm keeps alarming in the ventilator. So that is one of the indirect indicators. Then bronchospasm, coarse crepitation. These are all the common things which you suspect ventilator-associated pneumonia. But in this question, I would like to say ventilator-associated events. This is something new terminology which you can go through in Google. But I'll just tell you the superficial scenario. When to suspect, what they are saying is it is a surveillance suspicion for a ventilator patient, all ventilator patients. Suppose if you have a patient for 48 hours, there is no increase in oxygen requirement, there is no increase in peak requirements for 2 continuous days. And the third day, the patient requires a higher oxygen support, higher peak for more than 1 continuous hour, then that is the time you suspect along with this. So this is ventilator-associated event. Then what they say is IVAC, that is infection-related ventilator-associated complications. So those things like cough, production, all those complications will come. And then hypoxia again. And then you go for sputum, how to investigate and all that. So how is the patient monitored? Mainly in a ventilator patient, peak airway pressure alarm limits. Suddenly the pressure alarm limit keeps on checking, increasing. Nurse comes and tells you large volume secretions are coming, and the purulence, the quality of secretions also are high. The purulence or bad foul smelling sputum, and new onset bronchospasm or a crepitation. These are all the common things. How is the patient monitored? Continuous pulse oximetry and continuous. The other thing is radiological investigations. Radiological investigations, chest X-ray is a 2-dimensional view. Of course, as an intensivist, we do lung ultrasound for any deterioration in the patient. So that can pick up, because sometimes atelectasis also can mimic ventilator-associated pneumonia. Aspiration pneumonitis also can mimic. How do you differentiate? After some time, the X-ray shadows disappears. These are all the common causes of disappearing shadows after 48 hours. You will think it is VAP, but patient will be having atelectasis or what is that? Aspiration pneumonitis. Of course, ventilator-associated pneumonia is also a form of aspiration pneumonia only, but I'm just telling you all this. And then more important is monitoring the cuff pressure. So endotracheal cuff pressure, the nurses are supposed to monitor. At least make sure it is monitored once during each shift. And then the risk factor is the frequent disconnections. Make sure that you don't unnecessarily disconnect the circuit or change the ventilator circuit. These are all the common things.
How frequently is the imaging suggested for the
Madam, there are
VAP patients?
Yeah. Any increasing oxygen requirements or any deterioration in the clinical status of the patient, like hypotension or a hypoxia or a high peak airway pressure alarm limit keeps on coming every 1 hour, then and put up all these volume reductions. These are the 4 points. Immediately you will do a bedside chest X-ray imaging to know what is happening. If you have a lung ultrasound, very good, but in ICU we use lung ultrasounds. Worst come worst, shifting the patient for a CT, which will be ideal methodology. I don't think it is feasible practically, but if you have a suspicion and if the chest X-ray is not answering your question, you can do a CT chest.
Okay, sir.
Lung ultrasound is the same ultrasound what we use, or a separate probe, sir?
It is difficult because you need a separate probe. You can use a transabdominal probe, but the point is you need to have a separate setting for it. So the imaging becomes slightly different. You need to have a better frequency will be there, but the fine-tuning of THI and all tissue harmonic imaging and all will change. So resolution of the images change. So that unless the software is installed, it will be slightly difficult to pick up.
Okay. Okay. So these are the X-ray findings, the commonest organisms that we come across. Vijayalakshmi ma'am, can you? In short, say the common pathogens that are involved.
In discussion by Dr. Prabhu, so let's
Yeah,
make it very
that's
simple.
it.
So
Okay.
whatever is there in the hospital can produce.
This
Here
one.
I'm going to simplify it. Always look into the antibiogram. So majority of hospitals have two kinds of pathogens. One will be resistant coliforms and non-fermenters. When I'm talking about resistant coliforms, Klebsiella, which is resistant to carbapenem. Then
Little louder,
non-fermenters,
Vijay,
like,
please.
sorry, non-fermenters will be your Pseudomonas and Acinetobacter. So depending upon what is there in your hospital, you will have to choose the antibiotic empirically. In a hospital with good infection control, you should have a lot of ESBLs where you can get away with carbapenem. So if it is going to be a community acquired pneumonia, your pneumococci, staphylococci plays a role. If it is hospital acquired, generally in Indian setting, it is a gram-negative bug. Either it's Klebsiella, Pseudomonas, or Acinetobacter. MRSA comes in pockets in certain hospitals. Both the hospitals I work with, I hardly see MRSA. Enterococci is very rare. These are the organisms. Let's not go into a lot of details. It may be confusing to you. How do we prevent it? That is probably what we need now. So if somebody is on a ventilator, what is it we do to prevent an infection? First, make sure the head end is elevated. Head end should be at least more than 30 to 45 degrees above the bed level. Head end should always be elevated. You should give oral clad with chlorhexidine, so there is no colonization orally. Make sure the reflex is prevented, either PPIs or something like your Gaviscon or something has to be given for that. Every day, assess the ventilator can be taken off or not. Stop the sedation, assess whether the ventilator can be removed. This has to happen every day morning when everybody is around. Because once you leave it, night they may give some sedation, it becomes a never-ending cycle. Extubate them out of the ventilator as early as possible. Suctioning as much as possible, go for a closed suctioning rather than every time opening out and reusing the suction tubes. Simple measures, these are very effective in decreasing the incidence of ventilated associated pneumonia. Strict aseptic precautions, briefer duration of ventilatory care, and avoiding oral colonization, head and elevation goes a long way in prevention. So what is the morbidity mortality? It is related with purely the duration of ventilation. As the ventilation increases for longer period of time, chance of getting a pneumonia increases and the chance of patient coming out decreases. So our target should be as brief for the invasive ventilation as possible. We also noticed during the recent epidemic with COVID and flu, we can get away quite a bit of time with non-invasive ventilation. You're pregnant women, you may not be able to do all the time. But pure peril, always when it is possible, go for non-invasive mode of ventilation. And again, choice of antibiotic depends upon your ICU. In a hospital acquired, the choice will be either a carbapenem or something like a colistin or ceftazidime avibactam, depending upon what is there in your ICU. Thank you.
Okay. And this is the pathogenesis. And we'll go on to the sixth case. I think this has been dealt in detail by Dr. Vijay Lakshmi. Mrs. B, 28 years, a case of previous LSCS over diabetes complicating pregnancy, delivered by cesarean section, now complains of pain during micturition and frequency of micturition, complaints of loin pain, and she had been on a catheter for 3 days. So what is your probable clinical diagnosis and how to prevent iatrogenic UTI?
In this case, the patient may have gone in for a UTI and the infection could have ascended up, leading to acute pyelonephritis. Yep. And the measures in the sense, generally, pregnant patients are more prone for urinary tract infection, especially in the postpartum period. What happens is, due to prolonged labor, due to pressure of the presenting part, mild bladder edema can lead to retention of urine. And plus pain in the episiotomy due to the episiotomy wound or due to instrumental delivery that can cause a reflex inhibition of passage of urine. And oxytocin itself can act as an antidiuretic hormone, and all these can lead to retention of urine. So postnatally, you can ask the patient to avoid the urine and avoid retention of urine. And in the case of cesarean section, before putting the catheter should be done under strict aseptic precautions. And in a patient taken up for LSCS, you can do a douching before you take up the case for cesarean section, because chance of ascending infections into the urinary tract is more common. So by doing a clean vaginal toileting before cesarean section, all these can prevent iatrogenic infection. And unnecessarily, you need not keep the patient on catheter. Whenever the patient is mobile and the catheter can be removed, it can be removed as early as possible, ma'am.
And what are the complications if you're not properly managing an UTI? It can lead to
As she said, it could lead to the ascending infection further. So either it can be a cystitis or because especially we know in pregnancy and puerperium, the risks are higher, chances are higher. Cystitis and pyelonephritis. Of course, the incidence is not very high, 1 to 2%, but still it should be avoided if possible. And I think one important point is after cesarean section, when we are doing a vaginal, we clean the vagina and all, it's very, very important that we first clean the outside of, the vulval parts before introducing this, when we are trying to clean up the vagina. These small things, and of course, any day continuous catheterization has to be less, but at the same time, it is better than reinserting the catheter again and again. But definitely smaller periods of catheterization, either, in fact, nowadays they even say during the cesarean you put in, and after cesarean you can even take it out. But of course, our patients will not get up and pass urine, so that way, or for monitoring intake output, we need.
We keep it for 24 hours only, madam.
Yeah.
Okay. And Dr. Vijayalakshmi has emphasized on her case scenario on asymptomatic bacteriuria. So it is better to also have whether she had any kind of infection in the antenatal period. Mangalagita, can you say what is asymptomatic bacteriuria and importance where it leads to?
Geeta?
Preeti, you can answer.
Even in a patient who's not having any complaints, if the colony forms is more than 10 to the power of 5, it is called asymptomatic bacteria. Very common in pregnant patients, postnatal patients, and post-op patients. So only a culture sensitivity can give us the answer. So given asymptomatic bacteria in hand, all AN mothers, all postnatal mothers, all post-op mothers are at risk of puerperal sepsis. That's a point of concern with respect to asymptomatic bacteria.
At the 5th month of pregnancy.
Yes,
We
ma'am.
move on to the last case. Mrs. A, 22 years, primipara, delivered 2 weeks ago by labor natural. Now complains of pain and swelling in the right breast. History of fever, low grade for 2 days. No history of trauma. What's your clinic?
So mostly this lactating mothers, lactational mastitis, moving on to a breast abscess, ma'am. So mastitis or a breast abscess. Further clinical examination will give the clue of the diagnosis.
How will you diagnose a
And
breast abscess?
ma'am, when the patient is going to present to us with the postnatal or the post-op mother who's lactating, she's going to present to us with a tender swelling in the breast, and she's going to complain of fever, pain, and when we palpate her, we are going to have a definite tenderness. And once the diagnosis of breast abscess is made, then we move to the next step, ma'am. The treatment should start there, and that's what.
So what are the investigations you want to do at that point of time, and what is the best option that is available now? And will you advise breastfeeding during that point of time?
Madam, here the first is clinical suspicion. Second, a trial aspiration can give. We don't wait for fluctuation. That is one important thing. Only if there is a lump, tenderness, and we feel that there is some collection underneath because of the redness, we can just put in a trial needle aspiration. An ultrasound mammogram of the breast will give us the clear evidence where the collection is. It can be anatomically classified as subcutaneous, subareolar, intraorbitular, central, or retromammary abscess. And the predisposing factors in these cases are usually where there has been a cracked nipple or an inverted nipple. That is a common predisposing factor. And if the mother doesn't clean the area after each breastfeeding, the organisms from the oral cavity of the baby can keep infecting, and there can be an infection which leads on to this. So the option is always, once there is a collection, it has to be drained. Breastfeeding can be continued even after drainage. we do not just aspirate and leave it. We always make an incision, dependent drainage, and that avoids a recurrence. Whenever there has been an inadequate drainage, the last question comes, there is a recurrence. And the recurrence can also be due to an inverted nipple or a cracked nipple, which precipitates further occurrence of infection.
Angeline, I just want to ask you, like, is there a this thing role of empirical antibiotics? Sometimes they keep seeing and give. Or are you also worried about the antibioma or resistance or whatever?
Sure, madam. Antibioma is a cause of concern because most of the time, most people will be put on an antibiotic. So initially there will be a little reduction in the pain, and in breast we don't get a fluctuation. So people will keep on putting fomentation, things like that, and continuing till the whole breast becomes is converted into a bag of pus. Certain times it ulcerates and forms a mammary fistula. There will be actually a duct opening, and it will result in a fistulous opening that can happen under the near the areolar region. So that is a complication that can happen.
Previously, they used to say that you have to do an incision and drainage, but now aspiration of the pus itself is enough. Is that so, ma'am?
Madam, actually, this is a controversial argument because if you're doing an aspiration which is guided, ultrasound guided, and you are able to completely evacuate, then okay. Even then, there is a high then it has to be followed up with the culture sensitivity and an antibiotic because already there has been an infection. So most of the time, drain kept in the dependent position solves it easier. And always this has to be done in the OT under anesthesia. Trying to do it in the outpatient clinic with the local anesthesia leads to inadequate drainage. The loculi are not always opened up, and most of the time, depending on the anatomical classifications, we may not reach the. If it is only a subcutaneous stain, probably with this we'll continue. If it is going to be intralobular or retromammary, we'll miss all those things. So ideal anesthesia and a dependent drainage is better rather than an aspiration, madam.
How about aspirating, clearing it up, and then instilling local antibiotics? Does it work?
Can be tried if we have got a good that is imaging system and you are sure about the clearance, madam.
Yeah. So no chance of it going for breast cancer. This is the commonest question everyone.
Definitely not. Definitely not, ma'am.
Definitely it doesn't become a malignancy. But only thing that has to be kept in mind is there is one thing called as a inflammatory carcinoma of the breast, which is there, which actually happens during the time of pregnancy and lactation, which is a very, very dangerous form of malignancy. So that should not be confused with a breast abscess. This abscess doesn't become malignant, but an inflammatory malignancy of the breast. That is what is called as the carcinoma of the breast, which is during lactation, has to be kept in mind. That can be differentiated by your ultrasound, and if need be, if there is no collection and if there is a growth appearance of dense lesion underneath, a true cut biopsy will prove it, and that needs a totally different management apart from other than this abscess management, madam.
And breast care should start from day one of antenatal period. The day one she visits, we'll have to advise about the care, hygiene, about the inverted nipple, how she should take care of the area, everything, ma'am. And before and after breastfeeding, sterile
examination of the breast is more important. Many times we miss that. So when she comes, even with the inflammation or whatever it
mastitis
has
should
to be
never be overlooked.
Yes, so with that, we'll come to other I just wanted to summarize something. Sepsis remains a major cause of admission of pregnant women into the ICU and is a leading cause of maternal morbidity and mortality. The management should be as of non-pregnant women, including early recognition, fluid therapy, timely broad-spectrum antibiotics, and source control. And patients who survive sepsis often have long-term physical, psychological, and cognitive disabilities with significant healthcare and social implications, particularly in women who had been on ventilator and had pneumonia. Greatest attention had been on PPH and hypertension complicating pregnancies, 2 causes of maternal mortality. However, the third direct cause, sepsis, received less attention. Most of the time, we feel that we are underdiagnosing or we get patients right with septic shock. So, great attention, research, and programming should be done in this field. What we commonly recommend is early recognition, diagnosis, and prompt treatment. Maintain sepsis during birth. Any procedure you do in obstetrics, as Dr. Vijayalakshmi said, maintain sepsis. Perform rigorous hand washing. Make minimal use of invasive procedures, particularly catheterization. Teach women about the signs and symptoms of genital tract infections. And failure to recognize sepsis early is a significant cause and preventable cause of morbidity, resulting in delayed treatment and escalated care, which are critical if lives are to be saved. So you have to recognize and treat, and both the maternal perspective and neonatal perspective had to be taken into mind. It not only affects the maternal morbidity and mortality. MDG goal 4.2 says reducing IMR, you have to pay attention to reduce maternal infection. Intraamniotic infections causes neonatal sepsis, pneumonia, and respiratory distress and long-term neurological impairment in infants. So controlling sepsis not only reduces your MMR as well as an IMR, which is the 2 main indicators of our quality of life. So this is criteria for, these are the early growth therapy. And sepsis seeks to be delivered within 1 hour. This, I just wanted to tell our postgraduates because, as Madam said, the golden period is whenever you happen to have a case, within 1 hour, you have to give high flow oxygen, blood, and other relevant cultures, administer broad spectrum antibiotics, measure serum lactate or alternative, start IV fluid resuscitation with crystalloids, and accurate urine output measurement, as Dr. Prabhu insisted. When you monitor the signs of sepsis, definitely you can identify, diagnose sepsis and treat at the earliest. At this juncture, I'd like to thank all my panelists who gave their valuable opinion on all the 6 cases which we had commonly dealt in our hospital. And at this point, I'd like to thank Oxy for giving us a wonderful opportunity to moderate this panel. And thanks all the participants who stayed till the end to have their input from all our panelists. Thank you once again.
Thank you, Kalai. That was a wonderful moderation.
Thank you, Kalai. It's really an extensive topic. Sepsis is a huge topic, which was very well covered in the short time provided. The case selection was good, and the interaction from the panelists, we were able to drive in important points that need to be taken. Really an excellent panel. A huge topic covered. Less spoken about topic, as has already been told by everybody. It's not, sepsis is not taken that much in the panels as the HDP, and as you said, yes. And the fact that it is being covered, and it is really most of the aspects which
practical, Raji.
Yes, and tips given to the postgraduates that you have done. Thank you so much. It's my privilege, and I'm really happy to deliver the word of thanks. It was a very enlightening and an interesting session on infections in pregnancy. I'd like to thank first our dynamic president, Dr. Jayarani Kamaraj, and our efficient secretary, Dr. Kundavi, for time and again encouraging us to conduct these webinars. A big thank you from the bottom of my heart to our chief guest, Dr. Alka Madam, who could spare her time and come in and give her words of wisdom, and also our guest of honor, Dr. Vidya Tobi Madam, for their gracious participation and giving in their outputs, giving in their inputs and words of encouragement. Okay, thank you, Dr. Palaniappan, for a stunning start, and Vijay Balakrishnan for giving us such a lucid talk. Thank you, Dr. Kalaivani, my dear friend, who readily accepted to deliberate this panel. It's a huge topic and it needed a lot of input, a lot of effort to take in the cases, and you could spare this time for us with your busy schedule. Thank you so much, Dr. Kalai. And I should thank each and every one of the panelists also, Dr. Mangalagita, Dr. Preeti, Dr. Vidya, for all your inputs. You have taken the pain to go through and give us all the inputs and points for the PGs. Thank you, Dr. Vijay Balakrishnan, for your inputs, and Prabhu sir. We really had a lot of inputs from you, which we do not know. A lot of points which we have learned today. You've been very clear in the whatever we need to do when we have to refer to when we will have to refer to intensivist, and what are the points that need to be covered. And finally, Angeline, madam, yes, you've given us a clear idea of from the preparation of the skin, how do you take up the case, and what are the causes of sepsis, and how do you handle, and about the handling of fasciitis, where you need to do, about the negative pressure that is being done in government institutions was also an eye-opener for us. And
low resource setting.
Yeah, it was
Low
a
resource
very
setting.
pardon?
Low resource setting, 300 rupees, I think we can do something.
Yes,
correct. You are right.
really, this was the first time we have heard about it, and we came to know a lot of things from her as a plastic surgeon. And thank you for all of your time that you have taken.
Thank you, ma'am. Thank you too. Thank you for the opportunity.
Panel, a very interactive session and a very informative session. I would also like to extend my thanks to Shield Pharma for always being there for us and giving us this platform, and the wonderful audience for the enthusiastic participation. If not for them, we will not be continuing these webinars. Their encouragement, along with the encouragement from the President, Secretary, and the Oxy team, is what keeps us going. Thank you so much.
Thank you. Thank you, Raj.
Thank you, Rajashri. Thank you, Rajashri.
Thank you,